Hello world, my name is Kate Milliken and you've arrived at HIMSS 19 in Orlando, Florida. This is day 2 of our live coverage. Yesterday, we spoke to over 30 individuals focused on making change in healthcare. Today, we are continuing those conversations. So let's go to Ben Choder, who is president of West DMS, to hear more.
Thank you, Kate, and we're excited to be back for day 2 of HIMSS TV, powered by West, live from HIMSS 19 in Orlando, Florida. Today, we'll be hearing a focus on women in healthcare IT and how they are making a difference in healthcare. Don't miss the innovation panel coming up soon on moving healthcare communications into the future, where my colleague, Daniel Lotsoff, and the CMO of Variance Health will discuss how organizations are using technology to engage with providers, patients, and employees. Enjoy today's show.
West, technology-enabled solutions that move your communications into the future. Patient engagement solutions that support you in solving the complex communication challenges associated with patient experience, patient care, patient access, and revenue cycle management. Digital media solutions that help you target the right audience, communicate across multiple channels, and monitor the impact of your messages. Visit us in booth 659.
With me now is Tom Leary, who is the Vice President of Government Relations for HIMSS. Tom, thank you for joining us.
Thanks for having me here, Kate.
This is an important subject these days in terms of change. So to start, what are some of the things and developments that we are looking into in terms of government policy that are happening?
So the community is very excited for a few items that are hopefully coming out this week around interoperability. And we've been waiting for just about 18 months now for a information blocking rule to come out from the Office of the National Coordinator. And what it's going to be able to tell us is what's allowed and what's not allowed in terms of information sharing between hospitals and providers and just the community in general. And we're hoping for a couple of activities out of CMS around the Centers for Medicare and Medicaid Services around sharing data with consumers. They're all about two things, really. It's decreasing the burden for providers and increasing the information sharing with the consumers, the patients as consumers, as well as their caregivers. So it's early on in the week, we're hoping for some great activity there. Later in the week, we're very excited to have our friends from the Department of Defense here. The U.S. Department of Defense they're the agency that's been coming to HIMSS for the longest time, and their CIO, Pat Flanders, and then Major General Payne will both be presenting on activities that they've got underway, because what they're driving is they have the EHR activity around MHS Genesis. It's about a $5 billion endeavor of getting new EHRs into all of their healthcare facilities across the world. And so the healthcare community is really looking to them for what can we learn about the next steps in implementing, but more importantly, information sharing. And you'll hear that theme come up throughout the week of how can we get information to patients and their caregivers, and how can we better coordinate care between providers, both within the government system and out in and around the community.
Yeah, it's been really interesting already just to hear about how interoperability was kind of such a buzzword and such a monumental task to even start to get all of this information going. And now we're kind of onto this new chapter, right? That this data is here, how to make it accessible, and now putting policy around it. For you and your 5 years of experience in government relations, is there anything personally on top of all those things that you think is particularly pertinent to be watching?
Absolutely. How do we get information to providers in a way that they can make better decisions about the patient, the right patient at the right time, having that information. And the care coordination is really, it's the key component, the information that they'll have. And when you talk through that and you have the right information, you also have the idea of being able to make more responsible decisions around quality of the care, and therefore what government's looking for is what's known as value-based purchasing. So they want to pay for value, not volume. For many years, healthcare has been really paying for every time a patient walked through the door of the hospital or the provider got their payment. The government, want to really pay for not the number of times, but the quality of care that's received. Yeah. They'd rather pay for somebody staying at home,
right,
and having their chronic conditions taken care of than just paying for every time a diabetic has a sugar spike unnecessarily. Right. Those kinds of things.
Right, and data is now allowing that to happen.
Exactly.
Right, better information and telemedicine and whatever else.
So when I started with HIMSS, it was really a concept, and now we're at the point in healthcare where that data can flow and those great decisions can be made, and that's really what government's looking for. And from a HIMSS 19 perspective, the international community will also be here, and our government relations team is starting to work with them more often, and what they're, even though they may have a different healthcare structure than in the United States, or their payment system, for example, they're all looking for better decision-making, quality care, value-based care, not paying for volume. So what you'll see from some of our conversations this week, we're having some multinational sessions where a U.S. person is talking about privacy here in the United States, and an international person will be talking about the GDPR, the new privacy rule, for the EU.
Yep.
And so, how do those mesh? How can they learn from each other? How does something like the new California privacy law, how does that impact at the local area? That's really some of the conversation we're going to be engaging this year, because it's not just about what's happening in the U.S., but how can all of the countries learn from each other?
And it's like a whole new, now you're at a different point where you're actually having these conversations of things actually moving forward.
Exactly.
Which is super exciting. This year we have a whole different Congress, and I'm curious how, from your perspective, the Congress is going to affect health policy.
So Congress is really, the U.S. Congress this year is in the, they want to know an oversight mode. Mm-hmm. 2 years ago, the 21st Century Cures Act was passed with the idea of keeping the U.S. at the forefront of research and development and using technology to improve the quality of care. It's been 2 long years for in the policy realm, and now they want to see how the agencies are delivering. So that information blocking rule that I referenced earlier in the conversation, they're anxious to see, all right, how are you really going to pull this off, and how do we really begin to absolutely leverage the information from the technology that we've put such an investment in over the last 10 years. So in addition, the privacy conversation, we anticipate Congress beginning to look at, do we need to reopen HIPAA, for example? It's been the third rail for a lot of years, but are we finally at a point that HIPAA was passed in 1996. Yeah. It wasn't, smartphones were
way before this all
right.
start coming down the pike.
And so the idea of what is HIPAA? How is it restricting innovation, and how can innovation really be pushed forward by looking at possible changes to HIPAA? The other thing that's really tied in from a congressional perspective, as well as some of the agencies, is really that word innovation. We're expecting a lot of activity this week on the government side. Yeah. Congressional folks will be paying close attention to healthcare innovation this week. Yeah. And what changes do they possibly need to make this year to help further advance innovation?
Wow. So as a patient and an entrepreneur, you always hear about trying to make change with big healthcare entities, that it can be really difficult. Then you think about the government and you also think, wow, that sounds difficult too. Which in your mind is more challenging to actually move something big forward? Just a small question for you, Tom.
It's a great question, because as a parent, I've been through a situation where my son was on one side, the pediatrician was on one side of the street, the specialist was literally on the other side of the street, and then the clinic that they all interacted with was next door to the specialist, but the information had to be mailed to me. Right. And then I had to drive to work and fax it back to the pediatrician.
Oh, goodness. Wow.
We're not in that environment anymore, and that's really what the advent of innovation and information sharing and interoperability here in the United States, as well as around the world, that's the power of the possible. But the challenge, what government, it's always been a passion. So it's wonderful to figure out the puzzle pieces there as well. But if we can really make change, policy change and implementation change on behalf of the patient and their caregivers, I think that's what you'll see here at HIMSS 19, is we're really starting to make those changes.
And in the instance that you spoke about earlier, this whole idea of the government actually paying attention to what's happening in the healthcare space and making policy to move it forward.
Exactly.
Which is super exciting. You are kicking off an orientation event here at HIMSS. Tell us a little bit about it.
Sure. We always have newcomers come to HIMSS night, the HIMSS conference. So for HIMSS 19, we're doing it about HIMSS. The organization's undergone some great changes over the last 18 months. We have a new CEO who's been on board, Hal Wolf.
Yep.
We've got some new executive leadership team members. And how does the organization work? And as a cause-based not-for-profit, how do people get involved? So new folks come into HIMSS conference. Not only how do you navigate the conference, but we like to say that we're a 52-week-a-year organization,
right.
Not just
it's
this
not
week.
just this, right?
So how do you get involved, and how do you really help make change on behalf of your organization, your family, and your community? So for example, way back in the beginning of all the e-prescribing discussion, there was a small group of individuals that took it upon themselves to create a document that helped others avoid some of the pitfalls that they had come up against, policy side as well as technology side. That's really the spirit that I've seen with HIMSS, is that our membership likes to embrace the idea of teaching the next person how to be as successful or more successful than them. So the About HIMSS is really about how do newcomers get involved in that community.
Right. And actually, we had a chance to speak with Hal, who spoke about that whole idea of people coming into HIMSS with 3 questions and coming out with 6 answers. And that kind of back and forth, really trying to move things forward. Tom, so you are a Vice President of Government Relations. You also are the Executive Director of the HIMSS Foundation. Tell us a little bit about that.
So the HIMSS Foundation has been around for just about 25 years, and we provide scholarships and internships for college age and then graduate level students. This year, we're launching a donation campaign from our membership. So on Tuesday, we'll be talking about this. We'll be launching it from the HIMSS spot, and we're really trying to get our membership to embrace the goal of the foundation of developing the next level of leadership here in the organization. Those younger, the newer people here, get them those scholarships so they can become the leaders of tomorrow. So that will be launched on Tuesday afternoon.
So your hope is that the members will actually decide to donate to your campaign to pay it forward.
Pay it forward,
awesome.
Exactly.
Cool. Great conversation, Tom. Thank you so much.
Kate, thanks for having me.
With me now is Sergio Wagner, who is the Chief Strategy Officer and co-founder of Health Gorilla, and my new co-host, Jonah Comstock, who is the editor of Moby Health News. Sergio, I'd love to hear, just to start, an explanation of what Health Gorilla is, besides a great name.
Thank you. Well, Health Gorilla essentially has a simple mission. We want to empower physicians and patients gain access to the completeness of the medical data as it exists. As we have a platform that has the ability to ingest and sit on top of any existing healthcare legacy infrastructure, aggregate and normalize all of the data for the patient and for the physician to consume.
So how do you sort of stand out from the small crowd, but I feel like loud crowd of folks who are saying, we're doing it, we're the ones who are bringing the patient's data to them?
Well, obviously it's a very crowded field, so you're right. There's a lot of data aggregators, there's a lot of connectors. One of the things that makes us unique is the fact that, yes, we do the data aggregation and the data normalization and all of that great stuff, but also our solution is both physicians, patient, and enterprise facing. So we have the ability to aggregate all that data, create a normalized structure set, and provide a different viewpoint to each one of those constituents.
So for the people that decide to use your platform, they are given a certain data set, results of their own data, kind of aggregated in a way of AI, or bringing it together for insights that they understand?
Well, short answer is yes, but
Okay.
the important thing about that, everything begins with identity verification. So one of the greatest issues in healthcare is the security of the data and who owns the data and who has access to the data. So one of the at the core pillars of Health Gorilla is our algorithm to actually do data validation. So how do you know that it is Sergio Wagner in front of that iPhone trying to log set? So we created a solution that enables patients to do that, and once they've done that, have the ability to go and get their data, wherever that data may be.
What kind of insights do you feel that you have been able to learn as a result of this bigger data aggregation?
Well, you know, it's funny. I'll share a case that we did in Puerto Rico, and I'll obviously change the names. So one of our partners is the Puerto Rico Primary Care Association, who, you know, as an island, they've seen better days. And with the power of Health Gorilla, we have assisted the association in understanding better what their patients are. So we have the ability to have a patient, right? Let's call her Maria Gomez, a 72-year-old diabetic with renal manifestations, et cetera, et cetera. So it's a very sick patient. But because we can take all the data points, we also know that Maria has not seen a PCP in about 2 years.
Wow.
So because of that, the system, the patient, the doctor, the ecosystem can actually send Maria a secure message via our app and ask Maria, we haven't seen you in about 2 years. Well, Maria actually responded stating that she had no access to transportation, which is a social determinant of health. So oftentimes the payer could enable a measure like, I'll pay for your $10 cab ride. That could have an adverse in eliminating a $7,500 ER visit. So that's a real life example of how, you know, the power of data aggregation, but actually deployed in service of the doctor, the enterprise, and the patient, are better off.
So it's much bigger than just the data. It's everything that comes out of the data.
Well, data to me is the price of admission. So if you can't do that, then you shouldn't be in the space. But it's data in that of itself is good, but it's what insights can you get from the data? How can you help?
I also really appreciate the fact that the insights that you are getting may not only be clinical, but also social. So in the realm of people actually living their life, lifestyle factors, or whatever else.
Exactly.
This is an area that isn't clinically proven per se, but if you're actually talking about whether or not somebody's healthy, whether their life is going well, you know, I feel like things like having rides to the doctor, right? Add to the mix, reduce stress, or whatever else.
Completely agreed, completely agreed. And one of the new things that we're doing with our new product, Patient 360, is we'll enable already the ability for providers to aggregate data, whatever that data may be. We can tap into just about any health electronic record, most of them, I would say 90% of them, instantly. But the exciting thing is, what do we do with it next? So how do we really power that data? So one of the things that we're actually doing is we are trying to assist the provider, not compete with them. There's a lot of machine learning, and AI is a big trend, right? Everybody does AI.
It's a buzzword, but
it is definitely
it's
a buzzword.
true. There's things that are happening.
We want to put AI in the service of the practice and the patient. So for instance, if I was your patient and I was coming to see you, and we have done the hard work, right? We have aggregated the totality of Sergio's health information record.
Yeah.
But you're seeing me for a 10-minute visit. What is the information that you as a clinician should know and react to in that interval that you have? To me, that's the actual power of data, is to take all of that data, create an understanding of it, and present it to the physician so that the provider actually makes the clinical decisions that they need to make, rather than try to compete with them.
100%. Sergio, it sounds really interesting to me. Thank you so much for joining us.
Thank you so much.
With me now is my co-host, Dave Moyo, who is the associate editor of Moby Health News, and Carl Podorak, who is an MD and a medical director of applied clinical informatics at Mayo Clinic Hospital. So, Carl, I know that the Mayo Clinic is sophisticated in terms of its medical records. It ranks high in the MRAM scale. What have been some of the things you've seen that have come as a result of this implementation?
Well, I think we've been able to integrate our records across our entire system, and so that patients who are in one part of our system now, we're all on the same medical record, and it makes it very easy for us to get information no matter what part of our system patients have been seen in.
Now, Carl, you've done all this hard work, you put in the time, the investment. How's it turned around? Are you seeing any benefits in your institution?
We are actually. In our case, one of the things that we're seeing is we had a lot of legacy systems previously, a lot of individual departmental systems, unit systems, things like that we've been able to get rid of, kind of supporting those systems and just all work on one system. We've actually generated some ROI from getting rid of old systems that we no longer need to support.
And in terms of inoperability and silos, right, we've heard a lot about different silos and not being able to communicate with each other. So are you also dealing with that, even though you are sophisticated with your EHRs?
You know, I think we've had a lot of that in the past. That's been an issue, not just from a medical record standpoint, but just for a lot of reasons. And I think this kind of all being on the same system has really helped to start break that down. It's a process.
You're beginning to feel it.
We definitely are.
Yeah, that's great. And you are here to give a talk, so talk a little bit about that.
So I'm going to talk about data from wearable devices, the kind of the consumer grade things that people wear to count steps, heart rate, that sort of thing. That data's out there, it's being collected by the manufacturers of those devices, but up to this point, healthcare systems haven't really used that data very much for a lot of different reasons. There's some barriers to that, there's some challenges, but there's certainly a promise there of if the healthcare systems can get some of this data and link that up with outcomes, we may be able to do some prediction based on people's steps, heart rate, that sort of thing.
Dave, I'm sorry, I was just going to say, you know, seeing all these startups that are talking about, oh my gosh, we have something that's generating data. We're able to put it on a wearable. Mm-hmm. What's your experience of patients and consumers actually living through to wanting that data and working with it?
Well, it's really interesting that we're talking about consumer wearables as opposed to medical grade wearables that their hospitals are using them all the time. We're seeing all these deals with Fitbit and other major consumer wearable players that are putting these devices into the hands of patients on plans, mm-hmm. patients in systems, and generally, you know, there's data out there saying that the patients will stick with their devices if they like the device, if it looks nice, and from your perspective, if it's functional enough to get accurate readings that are usable and you can integrate them into your data system, there's no reason not to. It generally makes everyone happy if you can make it happen.
You feel the same way, that patients are adhering and wanting it?
Yeah, I think patients are definitely wanting, and one of the big barriers we have now is physicians and health systems don't always know what to do with this data.
Right.
And that's one of the things we're going to have
to
overcome.
This is something that we certainly learned. Carl, thank you so much for being on our show.
Thank you.
Thank you.
Thanks. So I do feel, you know, I had read that in the world of a Fitbit, when they first came out, it was such an exciting time and people so wanted to have this data. I had read that the average length of time someone uses one is 3 months.
Absolutely. Stickiness is a constant issue, whether it's Fitbit or other consumer brand companies. Clothing makers or shoe makers like Nike loves to talk about this. How do we get our devices with the people? How do we make them stay? Do we build it within a larger ecosystem? Yeah. Is it just a design issue? It's a constant struggle just from healthcare's perspective, but also just the people manufacturing these devices.
Yeah, and a continual conversation to be had. With us now is Stacy Cummings, who is a program executive of MHS Genesis. Stacy, it's great to see you.
Great to see you again, thank you.
So now that the DoD, Department of Defense, and the VA are deploying the same electronic health record, they finally got that together, what steps are you taking to leverage best practices?
So the DoD is fully supportive of the decision that the VA made to deploy the same electronic health record. Clearly, the Department of Defense has 9.5 million beneficiaries that are service members, veterans, and their families. And as service members are transitioning from the Department of Defense to the Department of Veterans Affairs, we want that to be as smooth and seamless as possible. And so working with our vendor team, we are under contract with the Leidos Partnership for Defense Health. Mm-hmm. We have worked with them to look at commercial best practices. We've also worked with other great organizations like HIMSS and CLASS to learn about what has been successful in the commercial space and then what is unique about the Department of Defense and the Department of Veterans Affairs as we're implementing a single integrated electronic health record. Uh-huh. Some of those best practices are around how we deploy our infrastructure, having the right bandwidth, making sure our circuits are in place, cybersecurity, leveraging the best of DoD cybersecurity as well as commercial cybersecurity best practices, and then training, having peer experts, making sure that we have highly trained people in the military treatment facilities, in the clinics, who can help the people that they're working with to adopt this new, modern, secure, connected electronic health record.
Now, I'm happy that you brought up cybersecurity. I'm going to bring you back a little bit. Obviously, sure. You're working with people's personal health data, and you're the government. Correct. Of course, cybersecurity has to be an issue. Can you talk a little bit more about what you're doing in that area?
Sure. So patient safety and securing our patients' critical data are our two highest priorities in the deployment of MHS Genesis. And we in the DoD hold ourselves to a very high standard for cybersecurity. And so we're approaching cybersecurity with a layered approach. So we're deploying a new network that is built with cybersecurity in mind. We're securing using the risk management framework and understanding what any vulnerabilities are associated with our medical devices, all the way back through the local area network, through the wide area network, to our data center in Kansas City. And our data center in Kansas City, we've done scans of the environment to make sure that we've patched any vulnerabilities. And I think one of the unique things that we're doing in the Department of Defense is regular adversarial assessments. So we bring in friendly hackers and we actually ask them to attack our system so that they can find things in advance of our adversaries and give us the opportunity to find new ways to secure, but also to monitor and defend our network.
I got to say, that's probably some kid's dream that they get to come in and hack the Army, you know what I mean? So what have you found actually makes your population different? You talked about, being distinct.
So the first thing that makes us different is we operate in an operational medicine environment. Yeah. So in theater, in a place where it's very austere, you don't have a lot of bandwidth, you don't have a lot of physical infrastructure. We also operate aboard ships, which is very unique. In fact, we have 2 hospital ships, the size of which rival a commercial hospital. They have surgical bays, they have ICU, a full-up hospital that floats.
Wow.
So those are definitely some uniquenesses to the Department of Defense. The other uniqueness is that our beneficiaries, our patients, as well as our providers and users, move on a regular basis.
Right.
And so the benefit of having all of our patients' data and having standard workflows, whether you're on the East Coast, West Coast, or overseas, from a patient perspective and from a user perspective, we standardize those workflows, and I, as a patient, have a consistent experience regardless of which facility
you can get it anywhere, whenever you're on your journey. Stacey, thank you so much for joining us.
Thank you. It was great to be here.
Good to see you again. Wow. So we actually had a chance to speak with Stacey Cummings and also Major General Lee Payne, who is an operating physician, and he spoke about what it was like for him when he was operating on the front lines. And now he has the ability with the technology to get a patient's record kind of pop up on his screen as somebody's coming in the emergency room. And what a huge difference.
It's a whole different meaning to point of care, huh?
I know. Yeah, for real. For real. Next on this show, we have Ben Moskovich, who is the Project Director of Health Information Technology from the Pew Charitable Trust. Ben, it's really nice to see you.
Thanks for having me.
Good, I'm glad. And I hope you've had a coffee, too.
Yeah.
With the adoptions of EHRs, what safety issues do you feel have arisen that you may not have anticipated in the beginning of the process?
Our research has shown that the usability of electronic health records can contribute to patient safety problems. When we talk about usability, it's both the layout and design of the system, but it's also how it's customized, how it's implemented within a healthcare facility, and how it's used by clinicians. One research study that we did with MedStar Health and other children's hospitals found that about 9,000 medication safety events that were identified, about a third of them were as a result, or the usability of the EHR contributed to those safety problems.
Wow.
So obviously we're here at HIMSS, everyone's talking about interoperability and data silos, protecting the data that's inside of those silos, but having one silo speak to another silo is a whole different ballgame. What type of work or protocols can we look into for protecting the communication between these silos?
We're working on 2 of the key challenges to interoperability and the exchange of data between those 2 silos. One is patient matching, which is how do you know that the patient in one record is the same as the patient in another record? Because patients' information changes, they move, patients have similar information, and so it can be difficult to match those records. Our research has found that there are 2 key ways to make progress. One is that if the data that are used to match those records are standardized, that can improve match rates. So for example, address can be formatted in different ways. If you standardize the way address is documented, then that can help link records. And the government can help make progress in that type of standardization.
We've also been talking to a gajillion people here, and a lot of them have spoken about AI, which I think started as a buzzword, but is now swiftly becoming real. What are the protocols you're putting in place to actually deal with the safety hazards of that? Because certainly AI in itself is moving faster and faster. It gets smarter and smarter. So what have you seen in your research there?
We haven't looked specifically at AI, but we have looked at some emerging technologies like biometrics. We conducted focus groups with patients on patient matching, and what we heard by a large portion of those patients was that they want to be using biometrics to help link their records. And that's because they use biometrics every day to unlock their smartphones or board a plane, and are increasingly using it in those daily lives. So why can't this advanced technology also be used to help foster interoperability? The problem is there's a bunch of key questions that need to be answered first, including around privacy and security. So what we plan to do is convene companies in this space and other experts and help establish a framework for the use of biometrics and other innovative technologies to help link records.
So Ben and I were talking about the vibe here, and it really feels optimistic. And I'm curious for you, if you're a researcher, you're really looking on what's real and what's not. You're learning from your mistakes. What are your feelings about being here in terms of progress?
Well, at the start of the week, there was a big moment in health IT, and that was the release of 2 regulations, one from the Office of the National Coordinator for Health IT, the other from the Centers for Medicare and Medicaid Services, that really set the groundwork for progress on health IT. And one of the common threads in both those regulations was the use of FHIR, which is a way to exchange data.
We spoke to Graham, right. And now it's really beginning to come together. Ben, I really appreciate you being on the show. Thank you.
Thanks for having me.
Thank you. Okay, thoughts?
Oh, man, can I say I agree? Is that a thought?
Yes,
does that count?
it counts. It counts.
These are all definitely huge issues, and the rule changes and the announcements at the beginning of the week that he was describing are a large deal, and they're going to influence what the field is doing for the next couple of years and whether or not everyone can come together.
Right, and the fact that actually there's change within the rules means like, you know what, this is really real, right?
Absolutely.
With us now is Sabra Eren Javia. You have to tell me if I got that right. Did I?
Close. Close.
Okay. Who's a section of hospital medicine and associate professor of medicine at Penn. Let's talk about, for you, what are you excited about here at HIMSS?
I'm really inspired by seeing everyone who's here and working so hard to improve the care that we're able to provide for patients. It's really exciting just to see everyone working towards this common goal and learning from each other and finding ways to collaborate with each other, which I think is really great. I think we're on a wave, or like starting a new wave of change in healthcare, and we've learned a lot from the last 10 years. I think we've done the best that we could with what we knew. And now I think we've learned so much to actually really change and take it in new directions that we haven't yet. So I'm really excited about that.
I have to say, happy you're here. I'm from the Philly area myself, so it's nice to have some Pennsylvania representation.
That's good.
Could you give me maybe a concrete example of what you're describing? You're describing the changes in the past 10 years, and you're seeing a lot of enthusiasm, excitement, and maybe some action here, and especially on the tech aspect and how it relates to care. Do you have anything you saw on the show floor in any of the sessions that has really blown your mind?
Yeah, I think one of the really exciting things that I'm learning about is integrating learning about the social determinants of health in the technology that we use to interface with our patients. A lot of what I've seen is using that to really, prescribe things to patients or help with our interactions with them. But I think another really creative way is bringing it into the clinician workflow so that while I'm still taking care of you in the hospital, for example, I can factor that into my care plan with you, or I can factor it into the discussions I have or my discharge planning. I think integrating that with apps and other technology that we use in our daily life, which feels so natural, but hasn't yet for medicine, is where I'm really excited to see technology become not almost a barrier or a thing we have to use, but something we're excited to use because it actually makes things easier.
I feel super excited to hear you say that. I feel the world has been, so I live with MS, I'm a patient, and I'm so aware of how sometimes when you're trying to talk about your journey, your health journey, that if it's not clinically proven, it hasn't been discussed. One small example is diet, right? That you say, I know I feel better when I don't eat dairy, and to have a neurologist say to you, well, I don't really want to hear about it because it's not clinically proven, is frustrating.
I can imagine.
For you, too, you have such a great compassionate doctor moment right there. Thank you, doctor. But for you to recognize, arguably social determinants are unstructured data, and the fact that you are thinking those through, putting them in the chart and recognizing that that may affect the overall lifestyle is huge.
Yeah.
Do you feel like that's a common trend within your practice?
I think it's a growing realization, and part of what we need to do is educate clinicians. I mean, the fact is we learn medicine based on evidence and based on books, and of course interacting with patients, but learning that our patients are people like us and have this whole other environment that affects their health is something that I don't think we have, at least not when I was in medical school, which was a little while ago, is not something that we talked about very much, but I think they're starting to bring that in more, integrating patients into the education process as well. But I love that you used the word journey, because it's really important. It's not just about that one moment. I might see you for a couple days in the hospital, but you have your whole life outside, and we might craft this great plan with everything controlled in the hospital,
right?
And it can be completely different with how it's implemented outside. So that's one of the things that I think we need to do a better job teaching clinicians and medical students and trainees is how do we see our patients as a whole person and factor that in.
Before you go, please pronounce your name correctly for the world.
It's Subha Eranjavia.
Thank you so much.
Thank you.
Dr.
Thank you very much.
Thank you.
So that's really meaningful to me in terms of the whole idea of looking holistically at a patient. And I'm sure at Moby Health seeing startups who are probably trying to recognize that stuff and make it part of the deal.
No, absolutely. Just so many focused on, especially with personal technologies that are such a part of digital medicine or personal medicine, being able to log what your experience is, communicate that to the provider, and enabling that through technology.
And what happens. It's really great. Up next, we have Adam Green, who is a JD, MPH, and a partner at Davis Wright Tremaine, LLP. It is really nice to meet you. You are a master in the world of security and compliance. Is that a fair statement?
I would say compliance more so, and I don't know about master. That's very nice of you to say, but it's what I do for a living, and I hope I know more than the next guy when possible.
Well, that's good. So I know that in the 90s you had the HITECH Act, which really started to incentivize EHRs to be part of hospitals. How do you feel like that's going in terms of integration and compliance?
So, I think the HITECH Act has certainly served its purpose in many respects in that there's been a sea change in getting people from paper to electronic. Now, obviously, I think we all know there's still a lot of goals that need to be achieved with respect to interoperability. On the compliance front, I think it complicated and challenged things in many respects. I mean, paper records were not naturally secure. I mean, they were getting breached all the time, but electronic records have really changed it to, the order of magnitude to what can go wrong when something, when a USB drive gets lost or stolen. And I think HITECH Act has caused a lot of confusion with respect to, we have an electronic medical record, do we just need to do a risk assessment of our EMR, and then we're fine? Do we need to worry about the rest? And, there was a lot of focuses strictly on meaningful use and getting that in place. And not necessarily realizing that, well, that's great if you've, addressed the risks of your EMR, but if the social security numbers in your billing software are going out the door, that's still a huge problem.
And that's just the hospitals that have moved ahead and pushed themselves into EHRs, EMRs. There's still, we saw in an earlier session, it was spoken here, of roughly 1 in 10 of these hospitals are still not fully electronic. How does that confusion you're describing that's happening to the majority of hospitals, we're not even considering the 10% that haven't made it there yet. What's going on with them?
Well, the HIPAA security rule has been around since, 2005 was the original compliance date. And so from that date on, people have known that they have to comply with the security rule. And from that date on, we've had large, sophisticated institutions that have invested huge amounts of resources into compliance. And then we've had pretty large portion of the population that the security rule kind of came and went and still are not, significantly beyond where they were back in 2000 with respect to security policies and procedures.
What's going to happen to them?
Well, there's always, it's always a roll of the dice. I mean, they understandably, their focus is oftentimes, patient care, and we don't have the time or resources to staff up and invest significantly in security. And patients oftentimes don't get to see that there's a lack of security. It's not like when I go into the doctor's office, I've got a Wi-Fi sniffer and I'm looking for vulnerabilities. So it really comes down to, do they get a breach and detect that breach? And at that point, they suddenly discover how much exposure they have by having not put in place a robust security rule program.
And also that patients will have a moment where they say, you know what, if you can't access my records, like, see you later. But that's a whole other conversation. It's really nice to see you, Adam. Thank you for being on our show.
Oh, my pleasure. Thank you for having me.
You know, one of the things that I would have loved to have asked Adam, because he's a HIPAA expert, is whether or not HIPAA needs to be modernized because it was started earlier or not, you know?
Absolutely. We're moving fully fledged, full speed in the digital age, and that changes everything from how we protect the patient's data, how we do care, and how we merge the two.
Right. Absolutely true. And, you know, actually I spoke to somebody who said that HIPAA, everyone's so scared of HIPAA, but it's not as bad as you think, and you can kind of work around it, or, again, another conversation.
Sure.
So we're here now with Patrick Sundstrom. Patrick, tell me a little bit about why you're here and what your background is.
I mean, if you're devoted to contribute to healthcare transformation, HIMSS 19 is really the place to be. It's like, you know, this kind of melting pot where private, public, technology and policy meet to exchange knowledge and create relationships. And we truly believe that to further catalyze the transformation of healthcare, we need to get public-private technology and policy to be aligned. And I'm convinced that the future of healthcare is going to be built on the strongest of partnerships. So that's why we're here from Sweden. We're here with a big delegation with top leaders from our healthcare providers, our industry, and our policymakers. So knowledge exchange, get the same experience, to take it home and to speed up innovation. So
I know very little about Sweden's innovation. Where do you fall in terms of other countries, in terms of being progressive?
I would say we are at the top, and we have, we have an ambitious goal. We have an ambitious goal to be the top leader in the world by 2025 in using technology to transform healthcare. And so we started that journey a lot of years ago. I mean, Sweden was one of those countries that digitized the first. The kind of movement we are in now is trying to move healthcare from bricks and walls of hospitals to the spot where the patient is. And obviously, technology and teams are the enablers.
Right, like meet the patient where they are.
Exactly.
Now, do you feel like when you have an older, so we know here in America, the whole world of the silver tsunami of older people coming through, and the argument that an older person won't adapt technology. Has that been the same for you?
We don't see that in Sweden, actually. It's something that we younger people think, and maybe, you know, the kind of healthcare providers and the professionals. But when we really make sure that these older people get the proper tools, they can handle it, and they are obsessed about it. And we've seen fantastic examples in the elderly care in Sweden. And I will also say that our main priority in Sweden is about managing chronic diseases and promote health. We truly believe that we have to discharge patients with digital solutions, with sensors, with training programs, with other stuff that makes continuous monitoring possible, and also to give out decision support systems and digital nudges that will prevent the chronic patient to get worse. So I think our goal is to support people to stay in a circle of well-being rather than get worse and need to go to hospitals or primary care centers.
Wow. It all sounds very ambitious.
So if I went online and I looked at the metrics of the success rates and the positive outcomes of Sweden compared to other countries, would it be like this?
No, it's not like that. I mean, we have our challenges as well, but we have some fundamental things in place, and we have it on a national level, and not many countries have that on a national level. We have a national service platform with services for every patient. So as a citizen, you can get access to your fully medical record online in a national service at the moment you want it. We have a national patient overview, so every healthcare provider could get access to data with the history of the patient, regardless of, you know, which kind of vendor you're using for EMRs and stuff like that. You can book appointments online, you can renew prescriptions, e-referrals,
So let me ask you this, that's all awesome.
Cool.
Give me your leading issue that you're dealing with.
My leading issue, because I'm working on policy level, so it's trying, all the regulations and rules we have in Sweden are really designed on yesterday's logic. We need to get the policies aligned to drive further innovation in healthcare and to make this great innovation we see at HIMSS 19 coming together in a sustainable way in Sweden.
But governments must see all the positives that are coming, which makes me think you're in for an easier fight to change those policies.
Yeah. I mean, it's our main topic, and in Sweden we have a decentralized system, so the regions are fully responsible for healthcare and they levy taxes, and the state has quite limited responsibility. It's about regulations and laws. So that's the main topic for our government.
Wonderful. Well, thank you so much for being on our show. We really, really appreciate it.
Thanks for having me.
I wish I could take more notes. Send them out. So enjoy the conference.
Thank you. Nice being here.
Cool. Wow. Fundamental changes from the get-go that I think seems very confident and clear that, that things are working,
Absolutely. And I don't know about you, I wasn't too well versed in Sweden's health initiatives. It's nice to get a refresher of what's going on across the ocean.
I agree. Well, this is what I think is so great about HIMSS too, is that they're so global and they so deeply care about connecting everybody. And case in point, I mean, you could argue that guy has a lot, and with his delegation has a lot that they've already figured out. The fact that they want to come here and learn is really, really cool.
Absolutely.
So, here we are next with Jean Petegin, I hope I got that right, who is the CEO and founder of Aduso Limited. And Jean, tell me a little bit about you and what you are working on.
I'm working on user experience on electronic health record systems.
Okay. So we've talked a lot about the headache of actually integrating an EHR. And one of the things that somebody spoke about is that when the HITECH Act came into fruition, people wanted to be so quick about getting it in that there was a lot of UI, UX issues.
Exactly.
A la too many clicks.
Yeah.
Right? So tell me how you're fixing that.
We have been doing our research in a couple of hospital districts in Finland, actually. So we are working in Nordic countries, but now we are looking at the US as well, because the challenges are pretty similar still in both sides of the pond, let's say so.
So do you feel like with what you see, you're doing the individual usability, do you feel like it also is possible for bigger systems to collaborate and work well together?
Yes, it is. And I think it's especially important to consider already like cross-border interoperability between the systems.
Yeah.
So that would help it a lot. And that would make it possible to also do some benchmarking. And I think that's important, and that can be done also in the US and also in the Nordic healthcare system.
Yeah, we have really found that there's been enormous progress in interoperability getting better.
Yeah.
The other thing that I think is interesting is technology coming in and what's happening to the physicians, right? Because you're trying to help them on their most simple form of an EHR, but now they have all these other things that supposedly are trying to help them further, right? And how are you watching them mitigate that issue?
Actually, I see that development in a way that now is the era of good EHR systems which are widely integrated and interoperable
wired
together.
That way? Yes.
And then the next step would be like bringing in those new apps and solutions.
Yeah.
So the good base with those next generation EHRs will make it possible to have those new gadgets and apps coming in and working with those systems.
But to do that, those EHRs, whether or not it seems like people in different systems are changing their own EHR system and individualizing it versus making massive system changes. Is that your experience?
So they are doing those kind of modifications.
Almost personalizing their own record.
Yeah. That's also important thing, that you can like really have individual, whatever works for you as a clinician or a patient or like customer. So if you can take your own patient data with you and make it usable in that way. Yeah, I feel that's very important.
But that seems like a pro, but also a con, right? Because if everybody is like personalizing their own system, how do you standardize it to make it better?
That's true. Yeah, actually.
Figure that out right now.
I'll do that.
It just seems like maybe HIMSS, 22, that will be like, wow, that was such a great idea to allow people to make it easier to use at an individual level.
Mm-hmm.
And yeah, anyway, so all good things to think about. It's really nice to have you on the show. Thank you for joining us. And your shirt, by the way, is amazing. And just want to throw that out there.
Thanks for having me here.
Awesome. Thank you.
Thank you.
I have definitely felt like I had read and heard that one of the biggest problems with EHR is the haste that you just didn't think about the UI UX. Like we weren't sophisticated enough.
Absolutely. And I think it's worth stopping on the point you're talking about, personalizing it to the individual institution. Healthcare, by its very nature, isn't one size fits all. And we're working on these problems of standardization and how to get one system work in the next system, but we still need to find a way to do that that allows for some wiggle room, because that's the reality of healthcare. It's what we have to work through.
Totally. With us now is Brian Mack, who is a manager of marketing and communications at the Great Lakes Health Connect. It's really nice to have you on the show, Brian.
Thanks for having me.
So,
I did.
Health Exchange, Brian Mack.
Yes.
Let's talk.
Yeah. So, Great Lakes Health Connect we are the leading a provider of health information exchange services and solutions in the state of Michigan.
Okay, hold on. Define health information exchange.
Okay, so health information exchange, how can I do that as quickly as possible? You know that the Affordable Care Act required that everybody be on electronic health records in terms of the providers across the continuum of care.
Yep.
The ACA did not specifically, well, actually the ACA also said that those health systems needed to be able to communicate with each other, but there was not infrastructure that existed to do that.
Right.
That's what Health Information Exchange did about 10 years ago.
Okay, so it's taking the silos of information that did get implemented, finding a way for it to all come together.
That is correct.
Okay.
Right.
In 10 years, that's a lot of time to put together a solution, and it seems like there's still a lot of progress being made, and at the same time, challenges to overcome. How's it changed over just the time period when this was mandated?
Yeah, I think that's a really accurate assessment, Dave, that it has been, there have been some pretty significant advancements at the local level. There are also some pretty significant challenges. I think one of those challenges is that the governmental dynamics from state to state differ a lot. When we talk about national interoperability, we really need to be focused on common standards across states, because you'll have states that are opt-in states. In other words, a patient has to give specific permission to allow their information to be shared.
Yeah.
Or opt-out states like Michigan, for example, which makes my job a heck of a lot easier, because patients are in unless they tell us they want to opt out. So, so that's been one of those challenges.
What is the country breakdown? Do you know offhand of how many states are opt-in, how many are opt-out?
I don't off the top of my head. I have looked at that information before. It varies from state to state, and some, I think, have not even addressed those issues. We know that some states, in terms of their regional and statewide health information exchange, infrastructure is very well developed. States like Michigan, states like Colorado, for example. And then there are others that have lagged behind, and again, it's largely because there's not a commonality of standard.
Right.
And so that it makes it challenging. I think that's some of the bad rap that regional health information exchange gets.
Right.
I was encouraged by Seema Verma's comments yesterday in the opening keynote, because we're all a little bit anxious about TEFCA and what that's going to mean when the final rule is ultimately released. But the assurances that she gave in the keynote led me to believe that they really are trying to take the dynamics that we are dealing with on the ground into consideration, and I really hope that we see that when the final rule is produced.
We've heard a lot of excitement about the CMS rules that were announced yesterday, which to me seems like a larger entity trying to be like, look, patients are important. Patient data should be shared.
Yeah.
Does that help you on a state level in some way?
I hope so. I really do. I think that a lot of I get really frustrated about the concept of interoperability, right? About that buzzword in particular.
Yep.
And it's because I don't think that there's a standard definition for the word interoperability. From my perspective at the local level, we are working with the providers at the point of care.
Right.
And there are things that we can do in that position that you're not going to accomplish through a national initiative.
Right, something this big. Right. And that's what a benefit to have it on the local level.
Exactly.
Brian, we really appreciate you being on the show. Thank you.
Thank you so much. Thanks for having me. My pleasure.
Welcome.
Good show. Thank you.
It is. We actually had some politicians on the show from New Jersey who were at the assemblywoman level, and how it was possible to make change. And so I think that the idea of states having their own prerogatives are like such a plus, but also a minus, you know, because for the people that make different choices, now it's not universal.
Well, I'm happy to hear that someone was from New Jersey. I mentioned before I'm near Pennsylvania, but I'm actually at home state, New Jersey.
Good.
It's great to hear that active work's being done back home.
Yes, that's definitely working out for you. Next, we have Lee Kim, who is the Director of Privacy and Security and the Interim Senior Counsel and Data Protection Officer at HIMSS. Lee, hi. How are you doing?
Hello.
So you are working on security and compliance with HIMSS. It's been a big topic, hearing about that. So what are you most excited about this year in terms of security?
In terms of the industry?
Sure.
We actually just published our 2019 HIMSS Cybersecurity Survey.
Mm-hmm.
It's available at www.hims.org/HIT security.
Okay.
And what I was most excited to see is a real trending with our questions in terms of more folks in the healthcare sector adopting best practices and more uniformity, being on the same page, raising their profile, as it were, their baseline in terms of security practices and actually best practices for industry. So that was wonderful to see. We're maturing.
That's awesome. And what type of work is HIMSS doing to ensure that a focus on privacy and awareness of privacy is infiltrating every corner of healthcare, from bottom level to the ground up to the tech providers to the healthcare providers?
Sure. So as a not-for-profit organization, we are connectors and we are also liaisons. Let me, being always a transparent person, let me just say this. So, we are, of course, one of many not-for-profit organizations and others that are helping to raise the roof, so to speak, in terms of privacy and cybersecurity. I think we all believe, we all know in our hearts, and we all believe that patient privacy is really important.
Mm-hmm.
And in fact, when you think about cybersecurity, it's not just simply some guy or gal in the back room making sure that the computers are secure and everything else. Cybersecurity folks are essentially in our frontline defense.
Yep.
Yeah.
So what we do as content experts and liaisons is that we connect with individuals from the private sector and also government to essentially confer and convene to essentially spark discussion and develop deliverables, as well as gather input and try to connect people so that as a greater whole we can raise the roof, as it were, in terms of cybersecurity. So in other words, we're trying to make it more cohesive, more connected, because right now the problem across actually privacy and cybersecurity generally is because there's misinformation, there's disinformation out there, and there's just way too much silo. And HIMSS, I mean, this is perfect, right? We're a global company.
Yes.
We're everywhere. We intend to be everywhere.
Yes,
we intend to do great things, right, in the world. And so we are the glue, we are the connectors, we're the conveners. We can't do it all. I'm sure that both of you know we can't do it all.
Right.
But
you're doing it. You're doing great work, and we see it here. Lee, thank you so much for being on our show.
Thank you very much.
Thank you. I feel like HIMSS has like a lot of arms.
Oh, absolutely. And
right?
as we were just saying, it's a global company. We're here in sunny, not so sunny today, but sunny Florida, and we have had guests that are from across the ocean talking about what their areas are doing. And really, HIMSS as a company, a nonprofit, is looking not just in the U.S., but across.
Right. And, the analytics department, your publications.
Media counts, too. We like to think so.
Look, I happen to be biased towards media myself, but I think it's all really important. Up next, we have Brian E. Dixon, who is a PhD and FHI-MSS research scientist at the Regentstrif Institute. How did I do?
Pretty close.
Okay.
Regan Street.
Thank you.
Yeah.
Regan Street Institute. Brian, tell us a little bit about what you do and what you're looking to find at HIMSS.
Sure. So I'm the Director of Public Health Informatics at the Regan Street Institute. And so I oversee kind of our efforts to try to make intelligent systems for population health. So I'm very interested here at HIMSS to look at new innovations and meet with partners or potential partners who are interested in working on improving population health using a lot of the newer methods and tools and innovations that are coming out of machine learning, computer science, artificial intelligence. So I'm very excited about what I see here.
And I'm sorry, I was to say population health, to define it, you have patients, you have communities, you have neighborhoods, and this is like massive groups of people and identifying trends.
Absolutely, yeah. So we're looking at, many health systems are interested in defining populations in different ways. So they want to either look at all the people that they manage care for, or all of the people who have a certain type of disease. But then we're also working with governmental public health agencies to look at the community level, as you mentioned, or both at the state health department level or the CDC. We also work at Regan Street with ministries of health in other countries. To look at population health in that context.
That's great.
Yeah.
And you're describing as intelligent design for these types of systems, and you mentioned some of the technologies that are going in. Obviously, you're working with so many people, so many different populations. There's just a wealth of data, and I assume that automation has to be coming into at least a certain aspect of your design. Can you talk a little bit about that?
Sure, yeah. We try to automate as much as possible because we think that automation will reduce burden on providers, so the people who are collecting the data, as well as reducing burden on those who are sort of receiving the data and trying to analyze it. So we're trying to build sort of dashboards that will auto-populate with data that's collected from routine care delivery, as well as pulling in data from other large data sets, so like the American Community Survey or the Behavioral Risk Factor Surveillance System data, so that we can automate the delivery of that data into dashboards, which will reduce burden on those who are trying to sort of look at population trends instead of working with individual data sets and trying to munge and manage those individually, right? Yeah. Which is a lot of work, and that's how we did things 20, 30 years ago. But now we're trying to automate as much as possible end to end and connect systems together.
You have such a fire hose now of data just spewing everywhere. What percentage of the data actually ends up not being helpful?
Well, a fair amount of it actually ends up not being. There's a lot of noise in the data, and so part of what we try to do through discovery is find out what signals are really important and powerful and can predict outcomes, and then where is the noise? Because there's a lot of noise, whether it be bad data that's in the systems or whether it be sort of useless variables. So we try to eliminate those systematically through our work.
Great. Well, Brian, keep going. Solve the world's problems, and I'll see you in a couple of years.
All right, thank you very much.
Thanks for being on the show. Great. I do think about how much data now can come through, and how do you make sense of it? And I think it's really cool finding ways to streamline it.
Absolutely, and just bring a little bit back around to what we were talking about maybe close to the beginning of the show.
Yeah.
Wearables, bringing those into the hospital, that's one of the biggest problems or challenges, I should say, facing this is just you're walking around, the data is being collected all the time. How do you disseminate what's important and bring it together? And
we also had an interview with the Google Cloud, right? And how they are taking different systems, whether or not it's mammograms, EHRs, whatever, and finding ways to do a query and bring in all data from all elements, which I think really specifies on a population.
It's exciting.
So we're here now with Christina Tagil. Christina, it's nice to meet you. Are you a doctor?
Yes, I am.
Okay. So talk to me about why you've come to HIMSS and what's exciting you about the healthcare landscape now.
Well, very exciting is when old medicine meets new technology, and I think that's what we can see at HIMSS. So there's a lot of new things going on, and this shift is really coming now. So that's why I'm here, to look around and scout around.
We've talked a lot in our conversations about the whole idea of patient first, which you know firsthand. But we feel like that definition has come up in three different ways, right? That you engage the patient to do what they're supposed to do to try to get better. You engage the patient as a person with care and compassion and empathy, and then the patient gets engaged as a consumer who starts to make choices. Where does your interest fall when you think about the patient?
Well, I think it's very important that they know what we want them to know, because patients today, they go out and they Google and they get scared. So if they come to our department, I think they should know what we would like to teach them about their diseases. So I think that's a very, very important thing to do, and also get their feedback, what they think about our treatment and questions directly to us, instead of going out and look for it.
Right.
Can you describe a little bit the direct interface the patients are interacting with your company? Is it an app or is it another service?
Yes. Well, I started this about 20 years ago, looking with machine learning and medical images, and that has now continued in empowering the patients with also information about the disease.
Exploding, right?
Yes, it is. Yeah. And also giving. I have a couple of apps, yes, and also tools for the physicians to use.
How do you feel, in your mind, how much do you feel a patient can take control of their own health and heal through information?
I think a lot more than we think, we believe. Before we took kind of all care of the patient, we didn't ask the patients. Now we should put much more into the patient's decision, I think, because they know their disease. They are sick 365 days a year, and we maybe meet them once or twice during that time. So we have to engage them to them to get better.
Right.
Yes.
Doctor, thank you so much for being on your show. And by the way, I totally agree with you. I think the power of the patient is huge. So good. Enjoy your conference.
Thank you very much. Right. Thank you.
We are now moving forward to a conversation I was able to have yesterday. Take a look. With us now is Assemblywoman Nancy Pinkin, who is part of the New Jersey General Assembly in District 18, and Sharif Elahal, who's a doctor and the Commissioner of Health in the state of New Jersey. We are thrilled to have you both here. I'm curious about what state New Jersey representatives are doing at HIMSS and what you're looking to find.
Well, I was invited by somebody who worked in health IT for many years. I've worked in health IT, not in it, but on the issues of health IT for many years. So I always wanted to come to the conference. I was so happy to have the opportunity. And data is so important when you're talking about limited resources. If you don't have data analysis, you're not going to be able to be efficient.
Sharif?
Well, just as the Assemblywoman was saying, I think it's a really exciting time in New Jersey for health IT and interoperability in particular. Over the last year, we've recruited 60 hospitals to the New Jersey Health Information Network. That's our statewide health information exchange. And I know that the Assembly in particular is very supportive of this work. I just testified as to all the benefits that could come from having seamless sharing of people's health information and really delivering their health information back to them for their use and their ownership.
You know, I do think the opioid crisis kind of pushed it over the edge, because people in the healthcare community, there's a little bit of competitive control that they want to have over their information. So they don't necessarily want to share because they want to keep those patients within their own system.
That's interesting.
That's my interpretation. But
why do you think that is?
Well, it's competition. You know, we have a competitive system. Every healthcare system is going into bigger and bigger systems. They have a much better opportunity to keep their own universe, and they do that by keeping the data and making it difficult to share that.
But the good news is that's where government can step in and make things different. So we were really clear about our desire for hospitals and clinics to connect to the health information exchange that we have, again, to really deliver the health information right to doctors and nurses who are taking care of patients so that they have all the information they need to make clinical decisions. And the rules that CMS announced yesterday force health plans to electronically deliver that information to people's smartphones, computers, really allows for us to catapult forward in this effort.
You know, and on that note, the health plans have a lot of data. And when you're talking about New Jersey is a fiscally constrained state, we have a lot of fiscal problems. We have a very large Medicaid budget, a lot of state employees. So when you talk about how you're going to be cost effective and meet your pension obligations and your budgetary obligations, the only way you can do that is by controlling those costs. And the only way you control the cost is by controlling that data and knowing where you're spending the most money, where you can be the most efficient.
Now that the hospitals have kind of joined forces and the providers, do you feel like they're beginning to understand the positives that are coming out of these choices you guys are making?
I think the physicians have, for many years they've put in data, and the struggle has been to get the data out and to be able to use it, both at the...
in terms of quantity or just access?
No, access to the data. So, for example, if you put in the immunizations on a child, you want to be able to get it back out. So if they went to a different physician, you could look in the record and see everybody's entering the data, but yet they couldn't get it out to find out, did they really have those shots or not have those shots, and what should they do when the patient's there the next time? You know, we have a number of registries. We have to get to that point of bringing them all together so there's an interface, and just the data overall, just to be able to quickly use that. And again, going back to the opioids, that's where things really came to a head, because people had to, it was mandated that they go into the PMP program, the physician monitoring program, and get that data. And not only to be able to get the data that they're putting in, but to get it live. So getting the data 5 days later doesn't really help if you want to see if somebody had an opioid today or yesterday.
Right.
And I would just add to say that physicians, nurses, and patients clearly see the value. To know that whoever is taking care of you when you go to an emergency room, for example, if you're traveling in a different part of the state, that doctor knows what you're allergic to, what medications you're already on, so that they don't prescribe something that you're allergic to is just one of many examples for why this is actually a patient safety issue.
Yeah.
I think that hospitals and clinics and the business around healthcare is starting to get there. They're starting to understand that things like quality reporting, interactions with government, the regulatory requirements we place on them can be automated, which will actually save them money over time so they can make that upfront investment.
They say sometimes that when one door closes, another one opens. For you guys that have made this progress, are there challenges now that are beginning to arise? Or too early to tell?
I think it's all been very positive. I mean, one of the things with the PMP, I think New Jersey's been a leader in the PMP program, but one of the issues came up was that, you know, we're a corridor state. We have New York, Pennsylvania, Connecticut close by, and people could easily cross over the border. And people that are learn that quickly, and they adjust to that. So it was making sure we could interface with the other states, and I think that transition was pretty rapid, so that we're expanding that opportunity, not just to think about New Jersey, but how to cross the borders and be able to be efficient.
Stephen, I want to bring you into this as somebody who's part of HIMSS, and there's a whole, governmental element to HIMSS. How much have you seen healthcare kind of get more on a political level to better, the providers and the way that the systems work within the states?
I think there's a drive across the board for states to try to make, as New Jersey's working towards, data more transparent, right? There's a move to make healthcare delivery more efficient, both from a cost perspective, but more importantly from the safety and improved outcomes for patients as well. And I think there's also just this expectation from patients that they get exceptional customer service digitally, right, in the consumer world. Increasingly, they receive that same level of experience for B2B transactions, yet healthcare has lagged traditionally behind that evolution. And I think the patient is becoming empowered like a consumer, right? And they're expecting their elected officials to help them have the same kind of improved and innovative care that they've already been used to getting from things like Amazon or Google or Microsoft for their consumer data delivery or phone service or whatever. So I think you're just seeing a natural trend play out here. And I think that elected officials are doing their best to help deliver policy.
To respond, right?
Will enable this innovation.
One of the things that was said today at the Leadership Policy Forum was that 1 out of every $5 goes to healthcare, and we can't sustain that. So even for the patient to have that consumer opportunity to control the record, we've been talking about having the consumers have control of their record for years now, but it hasn't happened yet. Right. So we're kind of teetering into that, but it just hasn't happened yet. So we need to have a lot more transformation, and I think we need to do more on the efficiency of managing the process in a facility, in a hospital, so we can start to barcode and look at the system flows and use innovation technology to get people in and out in the most rapid way possible, and using the resources efficiently. So that's a whole nother area that we have to capture to control those costs. We have an aging population, so the costs are going to grossly escalate.
Oh boy, do you ever, right? The silver tsunami coming through.
I couldn't agree more on the consumer expectations. I mean, right now, you go to any ATM in the world and you expect it to deliver money regardless of whatever bank you're a part of. And so as you have a newer generation of folks that grew up with technology, who are getting older, experiencing the healthcare system, handing them a clipboard isn't just going to cut it going forward. So I think this is the right time to make these transitions, and what's being announced from the federal government, from the work that the Assemblywoman and her chamber are doing, and the state government in New Jersey, all of that's really contributing to steps forward.
On the political landscape, a new Congress, how are you guys feeling about the way of the world?
Well, in New Jersey, we're so excited. We have a whole new delegation where we have a lot of great leadership positions. We have Congressman Pallone, who wrote the Affordable Care Act. He's now chair of the Commerce and Energy Committee, so that's a great opportunity. We have people on appropriations, people on Veterans Affairs, so it's a very exciting time for us. There's a lot of new energy. And the other thing that we're doing is we're working with other states again to kind of counter what's happening in Washington. So if it's talking about offshore drilling or cutting down the opportunity to get on the Affordable Care Act, we're working together across state lines to make sure we can be sure that we can address the needs of our residents.
And collaboration, I think, has really been something that in all domains, right, people are really beginning to do. You guys are amazing, especially your color coding. I know you're political because there's red, white, and blue in the mix, and I'm really glad you guys came to the show. Thank you for being with us.
Thanks so much for having us.
There's no teleprompter. There's no... Now on HIMSS, halfway through our show, and I'm excited to introduce the two of you. Why don't you guys introduce yourself?
Brian Fugere, I'm the Chief Marketing Officer with Verance Health.
And I'm Dan Lotsoff. I'm the Chief of Staff for West Digital Media Solutions.
Awesome. So you guys have both been in the realm of communications in healthcare for a long time. What do you think today, comparatively to years past, has changed, and what's been exciting for you in this kind of frontier that's been happening?
You know, I think what we see as a technology company and provider for digital offices is really, it's all about patient engagement now. That's the emerging space where people are really focused. There's a ton of money flowing into there, lots of new startups, lots of cool technology, but even the big boys are getting it right. If you look at Epic and their app that is on your phone called MyChart, it's probably the best patient engagement tool that's out there, and they win awards for it. All the other companies are like us are trying to catch up, but it's how do you engage with those patients using multimedia, different applications on their phones, whatever it takes. That's what people are trying to do today.
Right.
And Dan, do you think you give a concrete example of exactly what you said, how those initiatives moving forward?
Yeah, absolutely. So, I mean, one of the things that we like to focus on is how do you leverage video to improve the authenticity and speed of communication. So, for example, we have insurance organizations that are focused on how do they connect with the payer, from the payer to the provider, to educate them on new benefits claims or how to get paid. And so what we allow them to do is, instead of sending a person in a car for 9 months to reach 17,000 providers in a given state, we'll deliver it through video in one message. So instead of one message taking an entire year to deliver it, we can deliver hundreds of messages throughout the year through video.
I feel like the realm of video initially used to be so expensive also, and I think people understanding how powerful it can be as a medium is really coming around, right? On some level. The other thing is, it's funny to think about what personal engagement is, especially from a communications perspective, because when I hear patient engagement, what I think about is the telling of the personal story of the patient and how powerful reminding people that healthcare is personal through things like video is enormous. Can you guys speak to that?
Yeah, I think it's a great way. When you think about patient engagement, it's always from the provider out to the patient. That's the initial response. How do I engage them? How do I reach them? But what you're driving at is the other direction. And how do you remind the provider that it's an individual situation, my personal story, my struggle with the healthcare system, and that leveraging video for that is a really powerful way to do it. And nobody's done that yet.
Yeah, and I think the other reason why it's successful is it's authentic, right? You can see the person, you can see their reaction, you can see how they're having a dialogue and a conversation. That's why this is so much more natural than any one of us just doing a presentation.
Right.
So That's why we prefer that.
PowerPoint by way of the
Death by
dodo.
PowerPoint.
I know.
Exactly.
Yay!
Yeah.
I really believe that too. So, do you feel that in another thing that comes up with the realm of dealing with video production and making content from a provider standpoint is HIPAA? How do you guys circumvent that?
Well, we really don't, because you can't.
Okay.
But the video content that the providers will use is designed to educate and inspire. And so what we don't want to have happen is a patient ignores something and then a gap in care results. And so you want to inspire them to take an action to help with their own personal care. The education part is just the natural extension of that. And the video technique is really the most powerful way to do that.
Yeah, yeah. I mean, a perfect example is what we're doing here with HIMSS 19 and HIMSS TV, right? So there's 43,000 people that are here on site, and but there's probably 500,000 to 1 million people that would love to be consuming this content, and they just can't be there, right? You can't send everybody from your organization to this event, and so hopefully what we're able to do here is to broadcast this great content to a much larger audience.
Yeah. And I think the whole world of YouTube and general saturation in media, I do commend you guys for finding ways to make that video medium educational, because then you start thinking about what is the value. So for the value for me, when I am looking at video, is if I can find a patient story of someone living with MS who inspires me, I'm engaged, right? Like I'm inspired, and it actually sets the course of my healing. For you guys to actually find ways where you can engage people to be better through that content is important, because your biggest danger now with video is that everybody's beginning to do it.
Yep.
Right?
Yeah. It's a big challenge. I mean, I think speed to market is always important, but I think finding the right size of video is also, so snackable content, bite size, not trying to tell the whole story all in one picture is important. So that's what we really try and focus on, making it engaging, and to your point, a two-way conversation.
That's right, interactive.
Yeah.
So at HIMSS, have you guys felt something that, it would be amazing if there were video cameras everywhere. What have you guys seen that you have found especially interesting? Outside of your awesomeness.
I think that the realization now of all the big vendors that they can't do it all by themselves, and you're starting to see the strength of the ecosystem around each one of them. And if you walk around the show, what you'll see is a booth that says, I'm a partner of Epic or Google or Cerner or GE or
partner of.
And so those ecosystems are forming around the main vendors to provide those plugins to help the patients and help the providers get the full solution that they need.
Yeah. I think in the past, right, you had a bunch of point solutions solving individual problems, and now this greater ecosystem is working together to solve different challenges that are.
And the government is driving that through their push for interoperability, and it's smart and it's working.
Yeah.
That's great. You guys, please enjoy the rest of your conference. You look great on camera.
Thank you.
Throwing that out there. And thanks for joining us.
Appreciate it.
Cool.
Thank you.
So that's like my personal sweet spot. And actually what I wanted to ask you is, when you're seeing all these digital health startups at Moby Health News, are you seeing a lot of them that are using video?
Absolutely. Whether it's live video, so obviously telehealth is a large segment of the digital health initiative and all the efforts, but even custom-made content for individual patients, custom-made content for providers. We have some for seniors that can help them learn about or remember their previous days and their memories if they're starting to lose those.
I believe that, and I think that's really important to, make the money. Spend the money to do it, and I think that a lot of people, it has to be creative.
Yeah.
And I think that's hard for kind of more, official and conservative or providers or whatever else.
It's nice to have variety.
Not always. Yes, I totally agree. Okay, with us now is Andrew Mellon, who is a VP of Medical Informatics, who's also a physician at SureScripts. It's really nice to have you, Andrew, on the show. We've been talking a lot about power of the patient and the patient as consumer. And one thing that has certainly come up is the concept of price transparency. So what insights have you picked up here at HIMSS about that?
Sure, it's been a very important topic for us. We've, through the SureScripts Network Alliance, we have focused on this very heavily for the past year. Yesterday I had a panel with a number of representatives from the Alliance, practicing physicians and partners at major health technology vendors and Express Scripts. In addition, our CEO was on stage with the chief medical officers of Cigna and CVS today. So everyone's talking about this. And this is really about giving power to the patient and helping them make better choices when they're with their provider. It's about removing a lot of the information asymmetry and allowing the provider to make a choice that's both in the clinical best interest and the economic best interest of that patient within a shared decision-making framework. And we're still seeing really great results. We're seeing things like savings of $288 when psychiatrists make medication switches. We saw one patient that saved over $8,000 on a prescription simply by understanding that they can get the same medication at a different location. And we're seeing changes in efficiency. So removing the need 28% of the time on a drug with a prior authorization.
And let me just clarify that you guys have the ability to, if somebody has to get a medication, of having the ability to not only say, here's how much it costs, but if you don't like this, there may be other opportunities for other modalities for you to do.
Yeah. So, I mean, when we show that medication, there's options presented to the patient and the provider to have that discussion around what the choices are.
You would think it'd be everybody, you would think that would be something that everybody would do.
We think so, and we're seeing tremendous adoption. It's the fastest growing service we've ever provided. We've grown 1,300% in the past year.
Oh my God.
We have over 100,000 physicians.
Do you need to say that again? That is just like the best metric we've heard all conference.
1,300% over the past year. I mean, it's just, everyone is ready to do this. It's one of those things where the physicians are asking us for it. It's additional information that they find incredibly valuable.
Right.
And so it's been really exciting.
It's great. And in the spirit of removing barriers to data, information for all, interoperability. What is, from your perspective, is this the year that we're making progress in that space?
Yeah, I think so. I mean, it's this really interesting confluence of multiple factors. We see the government and other major entities really working hard to create an environment that's demanding the release of this information, demanding the ability for people to have control over it.
Great.
Secondarily, we have groups like CareEquality that have come together and removed a lot of the barriers, a lot of the administrative barriers, trust barriers that go into interoperability. And the third thing, technologies now that allow the interchange of data. And at SureScripts, one of the things we're offering or helping our customers, our partners with, is this ability to see where that patient has gotten information anywhere in the country. So one of the challenges with general sort of information exchanges, you often have to know where that patient's been. And sometimes
which is so helpful to kind of bring it all together and understand the context.
That's right.
Great.
And we can see where they've been anywhere in the country.
That's huge.
And help find that information with their permission.
Andrew, thank you so much for being on our show. Keep up the metrics.
Thanks.
It's amazing.
Thank you so much.
Yeah, great. What I think is super awesome about that is that maybe that there's an assumption that if you kind of open the kimono of understanding every price and what's going on, that people would lose money. And what I love is that they're kind of taking a bet that when you throw it out there and you're honest with people,
no reason not to. Sunlight's the best medicine, or the phrase is something along those lines. Sunlight XX something.
Yeah, right. The transparency, and it totally empowers the patient, which I think is important. So. Up next, we have Ryan Howells, who's a principal at Levitt Partners. Ryan, it's really nice to see you. Welcome to the show.
Thank you.
I am told you do a lot of work with health insurance and reforms, and I'm curious about the obstacles that you are facing in that domain.
Yeah, so we actually do some work there, but we also do some work with a group called the Caring Alliance. And the Caring Alliance is actually focused on patients getting digital access to their health information.
Okay.
And so yesterday at HIMSS, Administrator Verma was on stage talking about the rules that dropped on Monday, which were pretty
CMS
significant.
Rules?
That's right. And so we are focusing on the patient getting digital access to their complete health information, both clinical and claims information. So we are working with about 50 organizations in this company, including the largest payers and providers in the country, a lot of app vendors, and a lot of consumer advocates to make this happen.
It's 2019. We're seeing a lot of major shifts in the market, and just in their terms of strategy, we're seeing a lot of Amazoning healthcare systems putting a bunch of services together, pay-vider models. What does these types of transitions into new strategies mean, and how are they affecting your business?
Well, I think that what they're all trying to do is trying to find ways to empower the patient with actually the digital tools and the patient-specific health information that is necessary to be able to change the game. Yep. So most of these companies have a real difficult time trying to get access to the data. What we're trying to do is leverage what's called the HIPAA individual right of access to be able to extract the data outside of HIPAA to a patient's app of their choice and then redirect that information back into the HIPAA workflow, so to speak. And what that does is it allows for these third-party apps to then be able to access the data much more seamlessly than they can today and do it through standards-based means.
From your experience, why is it so important that patients get their own data?
So it's interesting because most of the people you talk to who don't believe it's important for patients to get access to the data are really healthy and have never had a significant health issue.
Wow.
But for those who have had significant health issues or have had loved ones or are caregivers to actually people that have had significant health issues, it's a really big deal to get access to all of your health information because for them it's very personal and it's very real. In fact, I just saw that Roger Savino, who runs actually the Office of Civil Rights, which oversees HIPAA for the whole country, just recently had trouble accessing his data.
Oh, gosh.
So when that happens, you have a really interesting means by which now they're going to really try to find ways to enforce the individual right of access, which is something we've had for 20 years, but before we've had to go to the basement of a hospital, print out different pages of an EHR. Now we have the ability to extract an API to a third-party app of their choice, and that allows you to get that information that you need at your fingertips. So we need more data with less friction.
Yeah, we actually had an EHR advocate on the show who had a dog that was sick, and the dog got sick, and then they were getting notifications. Has he taken his pills? And he had this stunning revelation of like, there's a major problem here. That my dog is getting better care and notifications than I am, and being incentivized. And that's sort of case in point, that as a result of him living that problem, right?
Oh, it's personal.
And this is what happens when you're sick, when you're an entrepreneur, you live a problem.
Right.
You realize there's a major issue, and how do you end up trying to fix it? And I think that's fantastic.
But it's every area of your life, right?
That's right.
So even when you're selecting benefit plans, if you have an employer-sponsored health insurance, the difficulty in selecting a benefit plan of your 10 years worth of health history, I don't know what to do. But in this way, if we have 10 years worth of history, at least the system will be able to recommend a plan that's best for us.
Exactly. That's awesome. Well, that is very encouraging, and I really love that story. So thank you for telling it.
You're totally welcome.
Enjoy the rest of your conference.
And if you're interested in more information, it's CarenAlliance.com. It's where you can get more information. So thank you.
Good.
Thank you. Appreciate it.
Thank you very much. So this has been an unbelievable conference. I got to go into the exhibition hall yesterday, and I don't know if it's totally clear how crazy these setups are, but it turns out that this arena has been up for an entire week, and people have been coming in for days to make these exhibition booths. They take about 5 days to put up. They cost hundreds and thousands of dollars, and they often are set up to be kind of a reception place in the day, but actually to change their vibe at night. So I found out that there are actually a number of disco balls in the exhibition hall, which means that after 5 o'clock, anything can happen. And yesterday, they have policies on how they want to, deal with how much sound people can have. And there was a major problem because somebody was breaking the decibel limit. And it turns out someone was using a chainsaw to create an ice sculpture. So hopefully that gives you some perspective of what we're dealing with here and how big and enormous it is and how much knowledge there is. And actually we got a tip from somebody that says it's so crazy here at HIMSS that the best way to deal with it is to actually simply pick a niche, dive in, and try to stay limited because it's so crazy. So next up, we now have Jonah Comstock, who also works at Moby Health News. He is the chief editor, and is that right? Yep. Good. And with us is Luis Gustavo Quiatake.
That's it.
Okay, I got it. Good. You are the president of SBIS Brazil. Tell us a little bit about what you do and what's exciting you.
All right. So we are leading the Health Informatics Society in Brazil, and well, we have many challenges over there. We have some new regulations that have been done in the last few days in Brazil, covering telemedicine, that we are open the telemedicine practices in Brazil, and there's huge discussion over there. The doctors are complaining a bit about the use of technology, and so it's a very interesting conversation, and that we can see here in HIMSS also tools and discuss the same problems that we have in Brazil and take the experience of many other countries. And we have also a very brand new legislation about privacy in Brazil, and we have some time to deploy it till next year. And we see that in Europe, the GDPR that is in place for some time, and HIPAA compliance that a long time are in place here in the US. And then we take all this experience to bring to Brazil and discuss that.
So on a world stage, people are kind of at different levels of how far they've gotten in being progressive. We had somebody earlier on the show who was from Sweden, and it seemed quite clear when I asked him, where do you fall on the global landscape in terms of progressive? He's like, oh, we're doing great. So where do you fall on that kind of scope of being more conservative or more progressive as a country?
Yes, well, we think that we have some very many common problems. The interoperability, privacy, and of course, Brazil is very particular. We have a huge country, but US also, but we have some health system is quite different. We have like the public health system and a private health system. So there are some particularities that are quite different. Yes. But it's amazing that we can discuss in terms of the deploying of the deployment of the technology. We are pretty like all over the world. Of course, if we're talking about, for example, Finland, that's a very small country. It's much easier to deploy a public...
That's a really good point about size.
I actually spoke with someone at this conference from Brazil who was working on a big teledermatology project in Sao Paulo, and Eduardo Corioli. He told me that the size of the city in Sao Paulo is just a huge...
Yeah, just in Sao Paulo we have 2,000 million people, so wow, Sao Paulo it's almost a country.
Yeah.
At the same time, we have some distant place that we need to cover also. And we have infrastructure problems for telecommunication, for example, and places that the doctors do not want to go there because it's so far away. And technology, it's a very good tool to cover that distant places. Well, moreover, we have the same discussion about analytics.
Yeah.
I suppose that it's a worldwide discussion and how to deploy, how to use it.
Sure.
And it's interesting that we are deploying. Yesterday, we have a very good in the keynote speakers talking about the public policies about open data.
Yeah.
And this is something that we are discussing also in Brazil. We have some protocols already in place to exchange information between providers and health plans.
Yep.
But we are aggregating in this protocol now clinical information.
Right.
So it's a very huge challenge.
Yes, it is. Luis, good luck. Keep fighting the good fight. And thank you for being on our show.
All right. Thank you too much.
Great.
I appreciate it.
So yesterday I had a chance to speak with Brian Eastwood, and here's a little of our conversation. Joining me now is Ligia Ricciardi, who is the Chief Transformation Officer of Carium, and Mike Milliard, who is an editor at Health IT News. I am thrilled to have you here. I feel like we should start by just explaining what Carium is.
Sure, absolutely. So Carium is a software company, and we build a platform for patient engagement. So we partner with other entities within the healthcare and wellness system to augment what they offer. So for example, if we work with a health system, we help their patients navigate among different programs and follow up from one appointment to the next. But we do more than just kind of logistics. We also help with things like nudges and reminders.
Now, Ligia, I remember you from kind of your past life when you were the consumerista at the Office of the National Coordinator for Health IT.
Yeah.
ONC yesterday, along with CMS, put out a pretty important rule that's been long awaited and talked about for quite a long time, the information blocking rule. What are your thoughts on that?
So I am pretty excited about it. That rule is in part about information blocking, which is really important, overcoming that problem. But the other part that's super exciting is that it really pushes forward this agenda that I've been working on for more than a decade in terms of getting patients access to their own data. And now health systems and also payer organizations that serve Medicare and Medicaid beneficiaries are going to be using APIs to get that data to patients. Part of why that's really important is not just because it's easier, but it really lets the data out so that we can get it outside of the healthcare system if patients choose to use it with apps and tools that help them sort of apply it to their daily lives. So that's really exciting, and it's very consistent with the long-term vision that I know several administrations have had. And I actually think that's a really nice thing about it too. It's been such a bipartisan effort and such a long time in the coming. You know, Bush, Obama, Trump, everybody's administration is all aligned around this area of digital health and empowering patients.
Yeah,
and that's terrific.
Finally, right?
Finally.
Yeah. And in the world of patient engagement, you certainly talk about, clinical things that can happen to make them better in terms of their wellness, nudging, reminders, also, having patients take control of their own health. So what are some things that you're excited about on how patients can empower themselves and get more engaged to be better?
Sure. So this idea of getting access to the information, again, is important in itself because people can do things as basic as just seeing errors in, for instance, what medication they're taking. Some people have noticed, like, wait a minute, I had a surgery on my right arm, not my left arm.
Right, I almost forgot that. I mean, it's hard to remember.
So it's like really basic things like that. It's not just reminders, but it's also you as a patient saying, wait a minute, this doesn't comport with what actually happened. I can help the whole health system avoid this error. But that's sort of just the starting point. Just information is great, but I think where the real power comes is where you can interpret the information into sort of usable knowledge. So that's things like daily nudges or reminders. You can really apply behavior change science so that we can use the way we think and are wired as humans to help us move toward rather than away from better health. So like example, without any nudges, you might be very inclined to eat a donut as opposed to, say, a salad. But if you kind of get these reminders that, wait a minute, your goal is to, whether it's avoid diabetes, lose 10 pounds, whatever it is that motivates you, play with your grandkids, you're going to be much more likely to be able to be true to what some folks call your future self, which is exciting because it takes a little bit of support to do that. Change is not just about knowledge, but it's about all kinds of motivation and reminders. It's deeper than just having the facts.
Yeah.
Having worked on both the policy side and now the consumer side, I'm curious, your take on a theme that seemed to be in the keynote this morning was that, the policy groundwork has been laid. There's been a lot of federal investment. Now it's really time for the private sector to kind of take that momentum, take that ball and run with it.
Yeah.
How do you see, is that fair to say?
Oh, absolutely. And I think, even back when I was in the federal government, one of the things that we did was hold challenges for the private sector to create incentives for smaller startups, certainly to enter this area of digital health. And that area has completely taken off. But it's also very exciting to see some of the biggest names in consumer tech and consumer-facing brands, whether it's Apple, Aetna, Amazon, all these folks moving into healthcare. Gets really interesting. Google, among others. It's, the majority, actually, the Fortune 50 companies are in healthcare one way or another.
Did you expect that would happen someday back in 2011 when you were at ONC? Did you think that Apple and Google would be the players that they are today?
Maybe not to this extent, but there were certainly hints that they were interested. I think the size and challenge of the problem in healthcare is big enough. And I think there's also a growing realization, not just by those companies, but more broadly, that health has to do with not just what happens in the doctor's office, but what happens every day in your life.
Of course.
Right?
Yeah.
Only the minority of your actual health status is influenced by that sort of time that you spend within the healthcare system.
Yeah. You've been waiting for a really long time. I would argue this is a small triumph for you personally, having waited for so long to see these types of results. I'm really glad you heard it yesterday, and we really appreciate you being on the show. Thanks, Ligia.
Thanks so much.
Thank you.
Riffin. Jonah Comstock, you have been traveling the floor, doing some panels. What has today been like for you?
I actually just came from the Venture Connect, which is sort of a Health 2.0 mini event here at HIMSS, and it's for investors and startups to talk about that VC angle on healthcare. And I had the pleasure of being on the opening panel with Megan Zweig from Rock Health and Indu Subaya from Health 2.0, of course. And we tackled the question of whether digital health is a bubble.
Mm-hmm. And the answer is yes or no?
We said no.
Okay, good. That's great.
So yeah, you heard it here first.
Good, thank you so much. So yesterday I also had a chance to speak with Greg Moore, who is here representing Google Cloud Solutions for healthcare. A lot of interesting stuff. Take a listen. With us now is Greg Moore, who is the Vice President of Healthcare at Google. Greg, what do you see as the biggest challenges in healthcare that your Google Cloud platform is positioned to solve?
Yeah, great question. You know, the world really hasn't seen the data being generated in healthcare before, like we're generating now. I'm a neuroradiologist by training, and so imaging has contributed an amazing amount of data to those workflows. Not only that, but genomics and the entire exhaust of healthcare is what we're seeing, whether that's wearables or from electronic healthcare records. So the biggest challenge is actually managing this data, and it's something our core competency at Google really is about managing data and then helping partners and customers do really interesting things with that data. I mentioned a few data sources, whether they're electronic health records, imaging, genomics. I came to Google about 3 years ago from a healthcare provider system. I've seen that all of those data sources are siloed.
Right.
In different places. So your electronic health records in one place, your imaging data is in a PACS system in another data system, your labs in another, your genomics is in another. And what we can do is actually, our core competency is actually bringing that data together onto common platforms to allow providers and companies to do really interesting and useful things with that, ultimately for patients.
Yep. Great.
Very interesting stuff, Greg. Could you tell us a little bit about how security cost and culture have impacted the move to the cloud by healthcare organizations?
Sure, we've seen a real change or evolution in this. For 3-4 years ago, people had security questions about the cloud. If you're talking to CIOs, we're now in an era where your data's not secure unless you are in the cloud. To do that, it's really how an enterprise can bring massive resources and security.
It actually makes it easier than a hospital, right? Hospitals used to think that you were a lot scarier, but not so much anymore.
Yeah, so a data center in a basement with what a hospital system can provide, we found out isn't always the most secure option to doing security at scale with the resources that a major enterprise player can bring to that equation. So it really is a core reason why we see companies and healthcare organizations actually moving to the cloud to take advantage of a secure and compliant environment where we can help them with other things like HIPAA compliance. With the product offerings.
So you talk about bringing all of this data together from different areas. How is the cloud able to actually generate insights? Is that a possibility at the moment?
Sure. So our mission in cloud as we do this is to really organize that data, make it secure as we talked about security and compliance, and make that data accessible, right? So we're strong supporters of open for that. And then to get to your question, is how do we make that data useful? And for us, making data useful is about machine learning and analytics. So at Google Cloud, our analytics engine is really our beating heart. It's called BigQuery. It actually allows you to bring all those data sources together and then begin to do things like visualization, begin to have clinical insights from that or business insights from that data. And from BigQuery, there's direct pipelines into our machine learning. So that's cloud machine learning. That's AutoML, which democratizes machine learning and means you don't have to have a staff of data scientists and machine learning engineers on staff to do that, that piece. So that really allows our partners and companies to begin to do interesting things with their data, and we're lowering the barriers for that. So really exciting times for us.
Yeah.
Craig, that's all very compelling, but how is all that technology coming together to enable real digital transformation in healthcare providers? How can they use that technology to, foster a culture of
to like bring it back to the providers, right?
Right. It is about enabling the providers to do what they care about and what they're passionate about, and to work in their core competency area. So let me give you an example, and this is from me being a doc. So at most healthcare systems, if you ask the simple query, tell me the women over age 50 in your healthcare system that are BRCA1 positive, the cancer gene, that haven't had a screening mammogram in the last 2 years. That turns out to be a very difficult query for any healthcare system in the US to have an answer. It takes an analyst to go away and produce a spreadsheet to do that. What we're enabling is by bringing these data silos together. That query I just talked about touched the EHR, touched in terms of the population health, women over age 50 in the demographic. It touched your genomics database, BRCA1 positive. It touched your imaging database. These don't talk to each other in most healthcare systems. By bringing that data together, we're enabling, on a common platform, BigQuery with what we've designed called the Google Cloud Healthcare API. On top of that, we've taught cloud to speak the healthcare language, if you will. We're allowing providers then to make queries like that to take care of their patients, which is their goal, making that easy for them to do that. So that's a real world example.
It's very cool to hear how it's actually moving forward now and streamlining. So congratulations, Greg, and thanks for being on our show.
Thank you so much, and really enjoyed the conversation.
Thank you.
Thanks. So Jonah, as the editor of Moby Health News, I know that you have your hand on the pulse of all the digital startups. I'm curious on whether or not you're seeing some sort of kind of saturation level or not.
Yeah, well, definitely as the years go on. I used to be kind of a walking encyclopedia. I knew all of the digital health startups and what they did. No longer. There's just too many.
Yeah. And for you, I also wonder whether or not, and for startups, whether or not they have to actually think outside the box in terms of what they're doing.
Yeah, I think definitely. In a crowded field, you want a narrow niche, and you want to do one thing really well. Yeah. But at the same time, hospitals don't want 1,000-point solutions.
Right, and that's something that we've learned now, like the saturation on that level too. But it is really exciting to see all the innovations, for sure.
Yeah, it's a push and pull, I think.
That's right. Now we have a conversation with Jorg Ammuller. Jonah and I are joined by Jorg Ammuller, who is the head of digitizing healthcare and the vice president of marketing for Siemens Healthineers. We're very happy to have you here, Jorg. And one of the, there's been so much in the technical world here at HIMSS. One of the buzzwords that is becoming clear is not a buzzword at all, is AI. And I know that's something you guys are working on. Talk to me about how you are putting it into the clinical space.
Yeah, you're right. I mean, thank you very much for posting that question. So, digitalization in general is a very important topic for us. So we see this as a major enabler to drive precision medicine, to also transform care delivery, and to also touch on improving patient experience. And this is where AI as a technology could help. You touched on that briefly. It's a buzzword. On the other hand, we are bringing this into clinical routine. So how do we do this? So on the first hand, you need to be capable to train this properly. Yeah? So you need to have a large amount of curated, annotated data, the supercomputing infrastructure, and also the experience on how to model algorithms like neural nets and also traditional machine learning approaches in that area. And on the other hand, to bring it into the clinical routine, the most important thing is how to overcome, or to integrate it into the workflows immediately. Yep. Yeah? And this is where we have our two digital companions. So the companion in terms of an assistant that could assist in radiology and could also assist in operating or performing clinical pathways for oncology and cardiology in that area.
This is an AI assistant.
Exactly. It's a software platform where we are able to interpret medical images, to assist in the workflow and automation in that area, and to also be accurate on operationalizing the decisions into clinical pathways. So how to enable objective decision making for a multidisciplinary team, diagnosticians and also clinicians.
Tell me about the data that you're working with. You know, everybody always says garbage in, garbage out when it comes to AI, right? So what kind of data do you feed into this system to get where you're going?
Exactly. So there are the data in that regards, so for example, for the pathway companion on the clinical paths is a multi-system data. Yeah? So it's also a data aggregation layer below that could aggregate data from like EMR, like from LIS systems, like from OIS systems and RIS systems, yeah, to feed that into. And on the other hand, to train those algorithms and test that, yeah. So we're using different data sets from like images, from like reports, biopsy data, genomics data in that regards to train the algorithms and validate them then for medical devices.
And the AI kind of puts all that different stuff together and makes it into something understandable and usable.
And easy, right? Because one of the big problems with clinicians is they end up getting such an influx of data that being able to have AI that gets them what they need, then they'll actually want to use it, correct?
It's like the situation representation of the right data at the right point for the right patient.
That's right.
Yeah? So that's the most important one. So the correlation of the different data points together. So if you look at the grade on where we should aggregate data, it's about accurately generating them first with our device fleets, for example. Then aggregating over overcoming interoperability challenges and going for a proper analysis, big data analysis afterwards to turn them into actionable insights. And then also last but not least, how to operationalize this data into the routine, into the workflow by then increasing the precision or also like improving the productivity and effectiveness.
Wow, you made that sound like it's so simple, which I know it's not.
It's a software solution that we apply for those clinical pathways. For sure, at the market, there are things like we have challenges on interoperability at the market, still a lot of silo data, a huge grade of unstructured data into that as well. AI can help there as well to, like, for example, use NLP to go through this one and increase the data, the grade of structured data. But these are things that are on a continuum to apply technologies to that market to drive those values like expanding precision medicine or transforming care delivery.
Right, and you're not alone in all of those challenges either. So how are you actually connecting care teams to their patients as well?
It's also a very important topic in regards to connectivity. So if you think of like Internet of Things, how could the things be connected to each other? Being it providers to patients, being it providers and providers. So what we do have here is like solutions that empower care management also in outpatient or core scenarios, like our eHealth platform where we have a provider portal and a patient portal. So to be able to access the data from the patient could upload data from sensors like wearables, but also from sensors from diagnostic tests like POC devices to those platforms and portals. And we are also capable to provide or to connect providers to each other to, for example, enable remote scanning with one operating room where like the knowledge is sitting and they can remotely steer then different devices in a virtual cockpit way.
Wow, that's really cool.
So a lot of possibilities.
I know, a lot of possibilities. Jörg, thank you so much for being on the show.
Thank you, it was a pleasure being here.
Thank you.
Have a good one. Thank you very much.
So we are back with my new co-host, Charles Alessi, who is the Chief
Clinical Officer of HIMSS.
Clinical Officer of HIMSS. And also with us are Tom Stafford, who is the Vice President and CIO of Halifax Health, and Keith Rail, who is a Senior Security Strategist for Fortinet. We're excited to talk to both of you. I know one of the themes that has come up over and over here is AI.
Really?
I know, aren't you surprised?
Okay,
Here's what the good news is that we've actually heard concrete things that are happening that are moving this forward. So talk to me a little bit about what you two know.
Well, I'll get started, but what's really exciting for me is a lot of the AI right now is focused on the clinical side, which is good, and I think it's going to help with clinical variation, and you probably are writing a book about this. But Fortinet is actually using AI in the cybersecurity world, and they did you should explain it, but what they created allows me to sleep better at night because this AI engine is watching essentially zero-day viruses that can come in, and he's sending me information to my firewalls and to my AV to make sure that it can see what's happening. But you can explain it.
Yeah, tell us a little bit about your technology.
Sure. So Fortinet's been at the AI game for about 8 years now. The technology has developed over time, and we primarily started out with analyzing malware with this system, and it would tear it into these little discrete packets or code blocks, if you will. And of course, over time, we had about a half a petabyte, fairly sizable file, of malware that we used to train this system. And it took 5.5 years just to train it.
But it got faster and faster.
It got faster and it got smarter as it went along. And so now we're at the point where we have 9 billion of these little code blocks that we use with this artificial intelligence engine to protect folks like Tom and let them sleep at night.
This is absolutely fascinating.
Okay.
And it's fascinating because everyone talks about AI as improving clinical outcomes. Everyone talks about AI as working with images, all the stuff we all know about. But what you're hitting on is something which is really of fundamental importance. As healthcare becomes more complex and becomes health and care, the number of players and actors increase dramatically.
Oh, yeah.
And as they do, clearly the risks increase dramatically. Well, suddenly, instead of one person interested in a record, you have a whole host of people interested in a record. Hence the potential to use AI to actually start to grade the levels of risk is absolutely essential.
Yeah.
And I think it's really important that we're looking at that now.
And this was probably the first real AI I had in the hospital. And you know, CMS is all about no harm and patient safety. But cyber is right in that. Yeah, because there's a ton of harm.
It's right in the heart of it.
Yeah, like if
what was
we
the barrier to
disrupt the
entry for you to do this?
The barrier is time. It's very, very difficult to get a system that's incredibly accurate, powerful, capable, fast. It's not like one of these little tents that you might see in the store where there are hoops and fabric and you throw them in the air and they pop open and you have a place to sleep. It's not like that. It takes a long time to develop an accurate, fast system.
And they did it smart, so I don't have the AI engine at my hospital. What I get is a feed from this AI engine up in Vancouver, I think, of all the, like the top 100 threats. And so it just sits there and it caches it on the firewall. And if it sees one occur, it's going to block it, and then I'm a lot safer.
Which, when we talk about all this technology coming in, one thing I've learned is that providers, in some ways, are beginning to resent it. It's like, look, I'm already so busy. So the whole way that you guys are laying out these threats and having it just work, right?
Well, our big concern is that we do it in a disruptive manner, and also an AI implementation should ease your burden, should ease you, calm you down a little bit, because it's there helping.
There is some education we need to do here as well, and it's education for the providers themselves, because all these initiatives are all very important, but sadly, a lot of people think they don't apply to them because I don't have a problem. So you expect me to spend money on something I don't have a problem for and I can't show a benefit of. And then, of course, one realizes what the effect of not doing something is. And then the economics change dramatically.
You could also argue that it's preventative, that even if the problem hadn't arisen, the fact you hit it at the core.
Absolutely.
Oh, it's completely preventative, because all he's done is strengthen my external firewall. And if I didn't have that tech, that email would come through, and a provider or a business team member could click on it, ingest malware into our production systems, and cause a lot of problems. And then no one's working, which is horrible.
Has this been a tough sell for you?
No. As a matter of fact, it's a very high demand, like when I go out and talk about it. Very, very high demand, very popular topic. And it's actually it's not looked at as an invasive going to take my job away. It's the enhancer.
It is
to making your job easier.
Much easier,
safer.
letting you sleep at night again.
And of course, as value-based systems, capitated systems become commoner, as different players start to play within this space, we're just at the foothills
of
what's going to happen.
Yeah.
So this is the start of something.
But this is the first time that I've seen AI in cyber. Because normally it's, like you said, imaging and clinical variation.
It's the obvious place to start.
And the back office stuff. And now it's like, and this is incredibly helpful, because one problem we always have with cyber is zero-day viruses, because no one knows what it looks like.
Yep.
and they figured out what the package looks like. And so it doesn't matter what the payload
You
is.
are an amazing testimonial for your technology, and I'm really glad you guys came on the show. Thank you.
Well,
thank you guys so much.
Thank you. Very
So
appreciate it.
here at HIMSS, we actually have 2 sets. We have one here at the table, and we get to once in a while be a little bit more comfortable. And yesterday, I got to hang out there on set B with Gurpreet Singh. With me now is Gurpreet Singh, who is the U.S. Health Services Sector Leader of PricewaterhouseCoopers. Gurpreet, thank you for joining us.
Thank you for having me.
So why are you here? And this is not an existential question, just to be clear, but what is exciting you about the healthcare space?
So the healthcare space is obviously very exciting for me. Last year when I was here, we were talking a lot about the vertical integration, right? So a lot of the big deals that were announced,
such as
CVS and Aetna, such as Cigna Express Scripts, such as Amazon, Berkshire Hathaway, JP Morgan, a lot of big vertical integration deals were announced at that point in time, right? So fast forward a year, so now where are we standing, right? And so many of those deals are starting to cultivate, they're starting to move forward, but we still have a similar concept and issue that's occurring, right? How are we organizing around the patient as a consumer? And how do we provide them with value? How do we provide them with access? How do we provide them with convenience?
For these big companies that have come together, and I'm almost going to put it into a verb, the Amazoning of healthcare, right? What are the benefits for them to do that, and what are the obstacles they face now that the patients are becoming consumers?
Sure. So one of the things that I think really interesting, maybe just to personalize it a little bit. So I have 2 sons. I have a 15 and 11-year-old, and both of them were at science camp, over the summer, and they were staying in the dorm, and we got a phone call from the school, and they said, "Well, your 11-year-old we think has a broken wrist." And so we said, "Okay." First question we asked was, how does an 11-year-old get a broken wrist at science camp?
Yeah.
Right. The second question we asked was, okay, well, how do we quickly triage whether this is truly a broken wrist or not? Right, and so we drive up. I live in Chicago, so we drive up north to the school that they're at, and we quickly take them to a urgent care clinic, right? Because we're maximizing access and we're maximizing convenience. Right now, I have friends that are at Northwestern University and University of Chicago, and they're physicians that are very well renowned.
Yep.
Right, and so of course I get the image, I text them the image, and do a little do-it-yourself healthcare, if you will, DIY healthcare.
Right, caregiver.
And they give me their quick recommendation. It looks like it's a clean break, and you might need to get it reduced. But probably the most convenient approach is to take them to a bone clinic that's maybe 5 miles away from where you are at the urgent care clinic.
Yeah.
And within maybe 30 to 45 minutes, they've reduced the fracture, they put him in a cast, and he's back at school. So what's just happened there? The funds flow has completely changed.
Yeah.
Right. It's moved away from the ER at those hospitals, and it's moved more towards those consumer-facing.
It's funny because somebody said to me, here we come. Everyone's talking about, ooh, the silver tsunami. It's so crazy, But that once that wave comes through, that the younger generation may just be like, I'm done with you, big hospital system.
Right.
And maybe that's the place where things really begin to change.
That's right. So we just recently wrote an article on the top trends for healthcare.
Okay.
And one of those trends that we talk about is the emergence of the Southwest Airlines of healthcare.
Wow.
And so while we don't have one today, you can start to think about what does Southwest do in their context, right? First, number one is they're operationally efficient. Right. They're very good at maximizing their planes, their turnover, their processes. They're very good at the operational efficiency, and they've built their business off of that. Number 2 is they're customer intimate. They know their customers well. They know the routes that they go on. If they have routes that have too much capacity, they'll immediately send a social media approach to actually getting them maybe a cheaper flight and do a promotion, and maybe change the rate structure on demand so that they can actually maximize that capacity. So you can start to look at that analog, if you will, and start to apply it to healthcare.
In all dimensions of health. I mean, even patient engagement, right? The difference between sending a text message to an 85-year-old and a 15-year-old.
You got it.
Right?
You got
Actually, somebody told me while they were treating in telehealth, one reason why it was working was because the 15-year-old loved looking at themselves while they were doing the physical therapy. You could see her eyes going, yeah, it looked great. And it is that whole way of thinking.
Yeah, and we've done some research, and we found that actually 75% of patients or consumers actually want to receive treatment via digital means.
Yeah, wow.
And actually on the flip side, 75% of physicians are willing to take data, whether it's from a phone, like a picture of, maybe your ear, or a picture like if, let's say, you had an otoscope, like to actually use that as part of their diagnosis.
Right.
And so we're seeing both on the consumer side and on the caregiver side that there's an emergence of wanting to use these new tools
and collaborate too.
Collaborate.
Awesome.
Yeah, exactly.
Repeat. We could talk for a long time.
We could.
But I'm shutting you down right now. Thank you for being here.
Thank you. Appreciate the time. Thanks a lot.
Thanks. We're joined now with Ashish Atreja, who is an MD, MPH, FACP, Associate Professor, and the Chief Innovation Officer, Medicine at the Icahn School of Medicine at Mount Sinai, which is my hospital. I'm so happy to have you here. So's Charles, I can tell.
Hi.
And I'm deeply curious, as an innovation officer, to hear your thoughts about kind of the digital transformation that's happening now.
Right. So we started 6 years ago at Sinai. I came from Cleveland Clinic. And that was, we need to build the capacity within Mount Sinai Health System or health system to actually provide value-based care. And we knew electronic health records alone would not do it because they are basically a transactional system. So we started mostly what we call as an innovation journey. What is possible? We have an in-house team of data scientists, user designers, app developers, and we embedded them in different clinical trial teams to say what is working, what is not working. And we were super successful in research setting. Our apps came in 15 countries, New York State, CDC, a lot of grants, efforts. But then 3 years ago, we realized research setting is completely different than actual transformation.
Yes.
You don't have a research coordinator who can actually walk the patient through. So the moment you take those things outside the research project, only 6% adoption of apps we were seeing.
Wow.
So a lot of our journey then last 3 years has been how to build platform which can engage patients right through their smartphone, actually prescribe apps and novel tools directly on their smartphone and engage them. And that has been our transformation journey. We call it from innovation to transformation and a fit journey. So it's been great. Now we have 92% engagement rate when we prescribe a patient an app and can kind of get the data back from them to engage them more.
Yeah, we've been very slow, haven't we? We've been really slow at understanding that the relationship between a clinician and an individual is not only therapeutic, insofar as therapeutics, as understood by some clinicians, means a chemical entity which they give somebody.
Right.
The pastoral role of clinicians, the way we accompany people through a life course, the way we develop a relationship with people is of fundamental importance. And I worry a lot about the fact that a lot of places haven't actually encapsulated the thinking in the way you have, because that's what you've done.
I would say also from a patient, I worry about it too. I mean, we've had a breakdown of a 45-minute appointment with my neurologist, and we said how much of it is personal. And it's 11 minutes.
Of course.
Right? And how sad that is.
Absolutely.
Right.
And we have an opportunity using technology to actually use technology as a clinical extender.
Right.
So I want to make your experience of me better than it is now, not because I use technology. I want to halve the time in which I spend my time talking to you, gaining your trust, assisting you in you making a decision about your life journey. And I think that's what you described.
That's correct.
And getting the people from the bottom of the organization to actually develop that, you've stopped what I've seen all too often as I travel around the world, seeing how people implement these things.
Yeah.
They get told, this is the only way you can drink a glass of water. Some people like another glass.
Yeah.
Why should I drink it out of that
Or maybe
glass?
what if I turn it sideways?
Yeah,
how
walk
will I
around
drink
this
that
side,
way?
yeah.
How about if I reverse the drinking process?
So getting people to own things,
Yeah.
that's exactly what you've done. And that's why you're successful.
And it's been a great journey. So we started with an app for GI, and we had a patient design group, which actually told us, and we actually flipped how the metrics of quality would be completely
You guys are always
opposite
flipping things. I know,
based on the feedback. And we realized that's how important for patients it is to know where they are in their journey, what is the status, what they can achieve. And I'll give an example, which actually started me on this journey when I was in Cleveland Clinic. I had a patient who came to me with 17, I'm a gastroenterologist, practice 20% of my time. That person had 17 bowel movements a day for 18 years.
Wow.
And I asked him what's happening. They said, oh, I have this disease, ulcerative colitis. It's normal to suffer when you are in this disease. So we had never been able to articulate most of the patients with ulcerative colitis can have novel bowel movements.
Yeah.
So when we did this design thinking group for our app, we tell them how you're feeling and objective score.
Yeah.
They were amazed to see what their score was, how bad their score was, and how much improvement they can have.
So you've reset normality for those individuals.
Although
so you've opened their lives.
You have to be careful about that, because if you put them, if they're not doing well, and you put them in the realm of, oh, your progression of your MS, let's say, yeah, you're not doing very well. That's a negative impact.
That's correct.
But I do appreciate what you're saying of at least educating people in a holistic way about the power of possibility. Yeah. And how much even that person knowing that it might be possible to only have 10, will that change of whether or not they actually do?
That's correct. And coming to your point, what we learned the second thing was exactly the same. Patients come in different phenotypes. Yeah. And some patients, you can't make them perfect 100% quality of life. Right. So they set up their targets along with the physician input. Right. So we say for you, because you had these many surgeries before, the target for you is this, and let's try to achieve that. Because you have to play with the concept of self-efficacy.
Yes.
You have to give them a goal which they feel they can meaningfully do.
Totally true.
And then also break down into weekly or monthly goals. Yeah. So it's not like happening after a year and they lose track.
Right. Well, the power of just little bits and how it does it whole. That's amazing. I hope we hang out at the conference more, because I would love to talk in light of what you're thinking. Thank you so much for being on our show.
It's a pleasure.
Yeah.
Thank you, Charles. Thank you, Katie.
Very exciting progressive thinking happening here. And yesterday we also had a progressive conversation with Stephen Blackwater, who's a PhD from Duke University. Joining me now is Stephen Blackwelder, who is a PhD, works at Duke University. Stephen, I am curious, we had a little talk before we went to air. Your role of data and machine learning and AI are all things that you deal with on a daily basis. Tell us a little bit about your work.
Sure. So at Duke University Health System, we have analytics that's embedded throughout the organization. And in my role in the IT shop, I get to help coordinate that activity across the organization, as well as support data scientists and clinical researchers and operational users as well, by providing an infrastructure that has the curated data that they can begin working with without their having to go all the way back to the EHR every single time they want something. So, so that those sort of machine learning models, the AI programming that gets built into the warp and woof of delivery of care, or that gets used in research with our patients and participants, all of that gets powered by the data that is a combination of what comes out of our EHR, what's available through claims, as well as increasingly things from patient swatches and other kinds of smart devices that are feeding kind of in an Internet of Things way. And we're channeling all of that into a place for a big treasure trove for the researchers to work from.
We've spoken a lot at this conference about the influx of data and how much data can come in, and sometimes that it's too much, and trying to find ways to pull from it that will be very effective for medical professionals. For you, with what you have created, how efficient have you made the data within your own system?
So I'll be completely honest, just between you and me here, nobody listening, right? So we have done an outstanding job of efficiency around delivery of data and analytics into the care provision part of the organization. So patient care operations gets what it needs and is able to act on the basis of that. And there's clinical decision support that informs doctors and guides clinicians in
so that they don't have to access their whole record. They know exactly what they need at the time they need it
Bingo.
most.
And so that part is all going very nicely. Where we're challenged, and what I spend a lot of my time running every day to keep up with, is the sort of frontier piece around data science. That's presenting challenges to data flow in all industries, not just within healthcare, but certainly within healthcare as well. So our data warehouse isn't sufficient to answer all of the needs of an artificial intelligence developer. Partly all the data might not be there, but even beyond content, it's not set up in a way that they're expecting it to be set up.
So that's the frontier challenge.
Exactly.
Is how can you take AI, take a huge pool of data, and have it stream through channels in a way that will make the technology work better?
Yes, we talk about pipelines for data. 10, 15 years ago, what a researcher wanted was essentially a flat file with the data skinny down to the pieces they were interested in. What a researcher, quite often and increasingly so, is interested in now is a continuous feed of the data, maybe for a subset of the patients, but a continuous feed of data that isn't a flat file, isn't updated nightly like a data warehouse might be, but is live in real time and continuous.
Wow. And as a result of that, is that because they kind of use it as a playground, or because things like machine learning and AI are so sophisticated that for them to get to the next level, it's almost like they have to feed it? Do you have to feed them O's and 1s to like make them work faster?
So plegground's a loaded term, of course, which I would never use.
Okay. Tell me why it's loaded.
Well, so we have this law in a set of regulations in the U.S. called HIPAA that you may have heard of. And there's sensitivity around the idea that somebody might be exposed to data, even though they're pursuing a project that's a righteous project, but they might be exposed to data that is more than what they minimally need to see.
I see.
So we don't typically provide a researcher with just carte blanche.
Everything, yeah.
So that's sort of the playground thing, or one way that playground could be interpreted.
Right.
But you're right that the initial stages of data science almost always involve somebody interacting and getting their hands dirty in the data and understanding what's there, what's not there, what does missingness look like, and do we see trends or other kinds of things that I'm going to want to use as a researcher. I'm deciding what methodology to apply. I'm going to bring some ensemble of models to this. I need to have messed with the data to understand that.
Right.
So the pipeline piece comes in that there's a handshake between the data scientist and, in our case, it's my folks in IT, where they're bringing some of their pipeline expertise and we're bringing some of our pipeline expertise. And the question is, where do we locate that handoff?
Right.
I'm trying to push the handoff as close to them as it makes sense to be.
I see.
Not any closer, but I certainly don't want them having to go all the way back to the HR every time they want something.
Peanut butter and chocolate.
There you go.
All right, Stephen, you're awesome. Good luck with everything, and thanks for being part of our show.
I appreciate the opportunity.
Thanks. Charles and I are pleased to welcome Jeff Livingstone, who is the VP of Global Life Sciences and Healthcare at Unisys. Jeff, welcome to the show.
Thank you.
One of the things that we've been hearing a lot about are actual medical devices, sensors, different types of wearables that people are using. I'm wondering your thoughts on that in terms of how they're helping people.
So yes, we're seeing a lot of the interconnectedness, right? The IoT of things bleed over into the health sensor community. But one of the things that is sort of being left aside is the security piece that actually traverses all of those. So
the dangers that come with
right. So it's not the same as, say, personal devices, because once again you're sort of using healthcare information to make actual health choices, and perhaps even providers are using these sensors and machines to actually choose routine care or provisions of care. So it's not the same thing as basically if I just sort of lose a credit card information or my iTunes library, right? It could be like I lose my entire patient profile, or maybe that has been changed in some way or modified in some way, right? So you could actually envision a case where hacktivists could get in and actually make changes in records on a device in a medical application, which is actually somehow connected to a sensor. So basically the readings are then false. So then if those sensor readings are being used by a medical device to essentially, say, inject a certain level of insulin, for example, right? You literally could potentially even kill the patient, right? So the security around this network, a fabric of devices is very important.
I mean, this is quite serious. Yeah. This is something I think we have been rather dilatory in actually addressing over a period of years. We have assumed that just because things do just one thing, we don't need to worry about them. And perhaps one day we didn't, because they were in a cupboard under the stairs somewhere else.
True.
Nobody cared.
True.
Now, when everything starts to be connected, now we really have a problem. Because unless everything is secure and we're relying on all of this information, we could very easily make the wrong decision for people.
But I think there's also a societal piece here, a cultural piece that makes it even more potentially impactful. If I am just a general consumer of products and materials, and I buy things, say, general retail on my personal device, for example. So to me, the expectation of privacy and security for using one kind of app and another kind of app, for say a medical application, for me perceptually, it's the same. It should be the same.
Right.
But it may not actually physically be.
Sure.
So I think that my retail experience, my personal retail experience, is identical to my health experience. But it's not, because in the back room, basically where these things are designed, those same elements of security and privacy have not yet been built in.
Right, right.
See?
It's a digital technology that's getting almost faster and faster in terms of what's being invented and having to catch up, realizing the problems. And one thing I know, having been here, is you close one door and another one totally opens,
yes.
and it's equally significant.
Yes.
And we really are dealing with complex adaptive systems, which is what health and care is.
Right.
And I compare it to a bubble you fill with, a balloon you fill with water.
Okay.
So you press it on one side to make sure you control it, and suddenly, oh, what's going on over there?
That's right.
And you're constantly grabbing it, and
right.
you've lost it. And I think having a secure, sensible, really well curated system is what we need. And I think we need that really quite urgently. So, I think it's really important and to highlight what you're doing.
How hard has it been to start putting these measures in place?
Well, see, here's the interesting thing. So, if you look at the way, if we just talk about, say, like the security piece of the puzzle for a moment, okay, not so much the design, the actual application design, right? You find that a lot of the vendors, the niche vendors, are really offering a piece or parcel of a gap. They're basically a gap-filling measure, right? But it's not really coming from like the end consumer, again, the experience out. So it's like I'm building in to out to like the business provider. I'm not really building from the customers, right. My client's client, if I'm a B2B, coming back into me, right? So we've sort of adopted that mindset and have come up with the idea of a security fabric.
Right.
Okay.
Right.
So,
which is a great first step to kind of dealing with this, to siphoning the balloon. We really appreciate you being on the show, Jeff.
Yes.
Thank you so much.
Okay. Thank you very much.
Thank you.
Thank you.
Hey.
Charles, I love your analogy. Unfortunately, now I'm going to see Jeff at the conference, and all I'm going to do is think of his head as a balloon.
It's so true. It's
right?
So true.
I know.
It's so true.
So how does that stop people from innovating? I mean, should people, when you know you're going to bring out another web of problems, stop?
It's our approach to manage all this stuff, because the way we measure is we measure on one little thing, not understanding that because we control one bit. Complex adaptive systems think of ways in which they do things differently to get over what we're trying to stop them doing.
Yeah, right.
So they
come right the other side. I know, it is crazy. Okay. With us now is Greg Williams, the Service Clinical Director of General Pediatrics of Starship Children's Health. First of all, wonderful shirt. Thank you for making us colorful. What is it that you are interested in looking at this conference, which is so enormous and so many topics?
Well, I've got lost a few times, but when I've found myself, it's when I've found people coming up with really clever solutions to the imperfect world of data we live in.
Yeah.
So none of us have, where I work, I certainly don't have perfect access to all the data I want.
Yeah.
But it's really cool to see how people are innovating to pull together all that disparate, imperfect information to make new meaning from it.
Where are you in your process at your hospital in terms of data?
We have access to, we're a long way away from having a fully fledged EMR. But what we do have is a single unique identifier across our health system. So at least we've got quite a lot of confidence in the person we think we're talking about is actually that person.
This is a big deal. I mean, who says, oh, and all we have is, oh. I mean, if only we actually managed to achieve a single identifier. I mean, that is a big issue. Instead of actually having to merge 83 systems or find a way to patch 83 systems or however many systems there are. So I think you're on the way. And I also think we need to be honest here and say that some people talk a particularly good talk. But we're all on this, as we're saying, we actually had a conversation yesterday, I think. We're all on this journey together.
Yes, that's true.
And perhaps let's understand that some are a little bit further in one bit, but not quite as further in the other bit. So I think you're doing great.
Well, in the in-between also of making a choice to try to discover what you can bring, what's the biggest opposition that you've faced?
I think there's such a huge need to build really good working relationships between tech and clinical staff. So I'm here,
Yeah.
I'm primarily a clinician.
You got your flag in the sand.
Yeah,
right?
that's right. But I can see just how powerful it is for both sides when tech and clinical get together and start working together.
And Charles, like that's right in your wheelhouse.
I mean, this is right it, because it's all about trust.
Right. And you were saying, representing your amazing, esteemed individuals in the clinical world, that sometimes they fight against it for reasons that don't really make sense. Is that a fair statement?
Well, yes.
Yeah.
Of course. But people are people,
Yeah.
and change is painful for all of us.
Yeah.
But if you are coming to me with some new innovation,
Yeah.
it can look really scary. But if I know you, and more importantly, if I trust you, we can have a decent conversation about it. And 99% of times we'll find a way to actually manage this better.
Right.
Those conversations don't happen often enough.
Finding a shared language is crucial as well.
Absolutely.
Isn't that interesting?
Absolutely.
I can talk clinical talk, which will be not particularly understandable to non-clinicians. So I try not to when I'm talking to other people.
Right.
And same from the tech point of view.
Yes.
I talk to my CIO and he starts talking about systems of record and systems of this, that and the other. And I'm slowly getting an understanding of what he means by that. And when I can understand it, I can see how we can work together and actually make use of this data that's out there.
Right.
Yes.
No, I do appreciate it.
Sad, isn't it? We both have developed our own language to make sure we don't understand each other.
And then, by the way, if you want to throw in the patient, now we've got three languages.
Now we've got three.
Remember me?
Yeah.
Right?
Yeah, absolutely.
It is. It's really hard to watch change from, the whole idea of what's important, right? And I do think that there has been, in the clinical world, this whole concept of importance is ranked by clinical proof. And for me, as a fierce patient advocate and an entrepreneur, it's not always about that. It's about time. It's about, lacking stress. It's about understanding yourself better and having the power to heal yourself. So before I get on this tirade and step up on a platform, I'm going to stop right here. Greg, I'm glad you're here. Thank you for joining us.
Thank you. Thanks for having me.
Right. Yeah, I really love that. Different languages from different patient populations or populations.
We're all tribes.
I know. And working really hard. So, to do the right thing or whatever else. Do you feel that when one person comes in from a clinical office and they're trying to fight the good fight as an individual, that they can make progress?
Oh, absolutely. If there's will,
yes.
And of course, also if they're empowered. Some of them aren't empowered to do that, but yes.
Yeah, no, I totally appreciate that.
Thank you.
So,
hello.
So we are now bringing on Gabriel Orthos, who is the CIO of the Central Georgia Health Network, and Jody Ingram. We're excited to see you both.
Thank you.
Subject, population health.
Yes.
How are you guys involved with it?
Yeah, absolutely. So we've been in a journey for population health management for the past 5 years. Central Georgia Health Network, our primary headquarters are in Macon, Georgia, which is about an hour south of Atlanta.
Yep.
And it's, everybody knows, we call it Atlanta without... Atlanta, yeah, exactly. The last T doesn't get pronounced.
He's going to sound really good saying that.
Exactly. So we're from the deep south. I'm originally from the deep south of Chile, Santiago, so that that gives you kind of a sense for so good football there, absolutely. But I've lived most of my life in Georgia, in Atlanta, and our network is comprised of 1,100 plus providers, 150 plus practices. Providers in the community that came together to create a CIN, Clinical Integration Network, right? Affiliated with a hospital in Macon, Georgia, which recently also got acquired by another big health system. So again, the chaotic kind of reality of our healthcare space, right? We've been in a contracting mode with our payers to try to expedite population health management in our communities.
Is it working?
Is it working? Absolutely, it's working, and it's all based on data and technology. And I think that we forget sometimes kind of that provider engagement and the importance of that provider engagement module.
I don't think we do.
Yeah, I know. Don't even get me started. Never. We're fierce over here.
Absolutely. Jody is really coming from the clinical side of the house. How do we implement these programs? How do we measure success? And I'll let her kind of explain what we do. I'm from the data side of the house, right? It's like, what kind of data? Is it claims? Is it clinical? Is it social determinants?
What's valid, right?
And
what's
it's not
important?
Exactly. What's valid, what's important. So I hate to get into a connect-a-thon of data and just give me everything. Right. But how are we going to do it for our patients and for our providers to show value and value to the payers as well, right? Because they are also paying us in these types of
So Jody, how has it worked for you from a clinician embracing this?
So I've been able to work well with our providers and build the relationship between our payers and our providers. We have a multitude of contracts. We have several value-based contracts as well, and each one of those gives us great information. However, if I go to a provider with 8 different payers and 8 different care gap reports, so we're working with Gabe to have an aggregate data, and the providers really want to do this. We have a very poor community. So we look at social determinants of health. We're looking at access through telehealth. But we've worked really hard. We have great relationships with our payers, and we're building that bridge together. The providers now have to trust the payers, and the payers have to trust the providers. And it is through those relationships that we're making success in that manner.
Now, as you can tell from my accent, I don't come from Atlanta.
I need you to say, go dogs! Woo, woo, woo.
And of course, coming from England, population health is what we've been doing in a state system for many, many years.
Absolutely.
And in my previous life, I was chair of the National Association of Primary Care. So I'm a primary care physician.
Right.
So you're speaking my language.
Absolutely.
And it's absolutely essential to reach out into populations, to speak language populations understand, to get to those hard-to-reach groups, because they're not hard to reach. We just speak the wrong language to reach them, as you know.
We're able to talk their language and put it in words that they understand, and let the providers know. If you look through the payer's lens, it looks like they're not doing what they need to be doing. But we educate our providers. We know you're providing this care. We just have to show the payers. And we've developed different clinical programs, clinical guidelines, educational tools, and we really have. We love our PCPs. We love you. And you don't want me to come to you with 8 care gap reports. You want us to come to you with 1, and that's where population health is going.
Yeah.
That's fantastic. It's a really unbelievable experience to watch also a clinician actually have to absorb all that information and put it into their daily life. So I commend you for wanting to make that effort, because it seems to me that there is a lot of work before you start to see the results. Has that been your experience?
We've done a tremendous amount of work in the education process, coding and documentation, just making sure that you provide a clear picture of what you've done to get it to the payers, where the payers can give you credit for it. And so we've broken down the barriers about that the payers want the providers to be successful. That's why they have all these value-based contracts. So we've really worked hard, and we are seeing success. We see our numbers go up over the past 3 years. I mean, we've had a tremendous climb. So we're not there yet. We're still working hard, and we're going to make it.
Yeah, that's great. You guys, it's really nice to hear. Also, seeing you guys together, working together, I think is a really important thing for the world to see.
So nurses can work with informaticists.
Yeah. Okay. There you go. I know it's a miracle. Thank you guys for being on the show.
Thank you so much.
So I love that when you get excited to have these guys speak your language, because seeing someone who's actually working on the data and a clinician wanting to come together.
Isn't that what it's about?
Yes, I think it should be about that, for sure.
Well, it is, and obviously the third person in that equation is the individual. I don't call them patient anymore. Patient is a very pejorative term.
Because it goes back to the white-coated...
We're talking about people, we're not talking about patients.
Right, that's right, and that they're not totally debilitated.
How are you?
Per se. So, with us now is Greg, who is the chair... I'm sorry?
Glenn,
I apologize.
Glenn.
You are the CEO of Livongo, right? Yes. And super interested to talk to you about what you're learning through your app. So why don't you explain what Livongo is?
Sure. Well, first of all, I should say that just recently, some new news for you, and that is I've now moved to executive chairman, and we brought on a new CEO to help us do what we're doing. And what we do is we're empowering people with chronic conditions to live better and healthier lives. So we're using a variety of technology, data science, and good old-fashioned people who have a lot of empathy to help people take charge and better manage their chronic conditions.
So I have MS. I want to use your platform. How do you make me feel better?
Okay, so first of all, we're giving you better information. We're making your life simpler. So let's say you have diabetes. So today, what you have to do is you have a glucometer. You have to remember to order your strips. You have to pay a copay. You have to write down all your information. And the beauty of our system is you no longer have copays. Your information is all given to you because you have a little screen that you look at. Your scripts are delivered automatically, and you don't have to write down your information anymore.
Yes, I mean,
you have 24/7 coaching available to you when you need it.
Wow. I mean, I've known you, Glenn, for how many years now? And I've seen the journey of Livongo turning. From the start, it was something which was absolutely extraordinary in my view because it empowered people. So it wasn't a window on something which they could just get a peek in. It turned everything upside down. It made the person actually control their own lives.
That's right.
And I think that is the most fundamental thing for me, which is most fundamental about
what you do. Today, healthcare is something that is done to us. And what we want to do is we want to flip that around, and we want to put people back in charge of their own healthcare, give them the information, because we think healthcare is an information business, give them devices that make their life easier rather than harder. You know, if you think about it, with all of the apps and all the coaches and all of the different things that we're doing, healthcare has actually become more noisy, more complex. And we're trying to make it less confusing, less complex, and less costly than ever before. And that's what we're doing at Livongo.
I feel, for what it's worth, that I think the power of the patient is completely undervalued in terms of getting them information to make themselves be better. So certainly the idea of engaging a patient with reminders and, you know, the actual treatment of their care is really important. But how do you actually make them believe that they can get better?
Well, I think that the first step is you have to trust in the people with diabetes. So we've changed the language. So I think if you want to change the world, you have to change the words. So we've changed the language. We've really trusted that people can actually make better decisions. And so we'll give them feedback. We'll give them real-time information. And then we watch them, and it's extraordinary because they want to be healthy.
There is a very well-defined way to do this. It's got a terrible name. It's called activation, because it sounds like you know, you turn something on. But the moment you activate people, you take control of your own life.
100%. We could go into that.
Changes.
And you've seen it over and over through your technology. That's wonderful. We need to stop. I'm really happy to have you on the show, and thank you for joining us.
Sure. Thank you very much.
Wonderful.
Thank you.
We are now onwards to a conversation with Jane Sensemeyer. I'm here now with Joyce Sensemeyer, who is the Vice President of Informatics from HIMSS North America. Joyce, I'm so happy to be here because I feel like the world of informatics is something that's hugely important at this conference.
It is.
And you've also been part of this world for 19 years. So
yes.
We have a lot to talk about. Why don't you define informatics and tell me what's been the most exciting element that you've seen so far up until now in that realm?
It's applying data and analyzing the data to see how we can use it, what it means. And I think the most exciting thing is there's a lot of collaboration now. People aren't just working in silos, they're working together, and that's enabling the data to be leveraged beyond one single point in time.
So as somebody who's been in the space for a long time, can you talk about kind of that process to collaboration?
It starts with listening and being open, and I think HIMSS is a great example of how that's done. We're a convener, but we also bring thought leaders together to really learn how they can work together and make a difference. It takes that listening to start the process.
I also feel like when people are creating new technologies, right, that it's a business, right? Yes. So perhaps that when this all began in terms of putting technology in the field, you know, it was people wanting to do better than the other person.
Right.
What happened after that point? Because suddenly you found yourself with these EHRs. Some people were having Cerner, some people were having Epic.
Yeah.
All of a sudden people wanted to communicate. Like, how did that shift?
The shift from proprietary to really the sharing, I think, revolved around the patient, wanting to make sure that the patient information is accessible to the clinicians. My background is nursing, so knowing that I needed it at the point of care, and the patient should, well, certainly today has access. So it shifted the conversation from one of the importance of sharing rather than keeping our data silos.
Right, and putting the patient first.
Right, even better, yes.
On some level. So you this morning also moderated a panel on interoperability.
Yes.
Talk to me a little bit about your background on that.
Sure, interoperability is a marathon, we heard at the keynote this morning. And
did you laugh? Were you like,
I did,
God, I'm
yes,
tired?
Absolutely related with that. So we've taken baby steps, we have standards, But one of the things that HIMSS does is bring the vendors together to test their systems to make sure that they are connecting and interoperable. So the journey continues, and we have an interoperability showcase here where we can show our attendees what is possible.
What are you most optimistic about in the past couple years that you've seen in the realm of interoperability?
I would say getting it to the point where the patient can access their own data. For example, I have a portal that I can go into and see my records and see my test results, and then have a conversation with my provider, through email exchange. So I think engaging the patient in that, then they better understand what care is being offered to them, what their options are, and have a good relationship with their provider. The days of are gone where our parents would say, oh, whatever the doctor said is fine. Those days are gone. So now it's really, you're a part of the decision.
Another thing that's come out through all these conversations we've had is looking at patient engagement on the actual kind of clinical elements of getting them to take their meds or whatever else, and also kind of engaging the patient in a way of empathy and humanity. Yeah. What is it like for you, having come from a nurse where you had to be empathetic, to being more in this kind of data-driven area, seeing both of those in play?
Yeah. What it has helped me see is why we're doing what we're doing. I understand that privacy, security, we're doing that to make sure the patient's information is safeguarded. And I can still see that patient, even though I'm not in a healthcare hospital environment anymore. I never forget that. Right. So it really makes you be a passionate champion of that.
Right, and you want to believe that doctors and medical professionals got involved because they deeply care about people.
They do, but I think sometimes the technology gets in the way and we forget, so it's really important to bring that conversation back.
Cool. Joyce, thank you so much for joining us, and good luck at this conference.
Thank you, Kate.
Joining us now is Sean McKee, who is the Vice President of Marketing at WebPT, based in Phoenix, Arizona. I know you guys well. I think you guys, WebPT is a wonderful demonstration of somebody seeing a problem and trying to fix it. So can you give a brief overview of what it is?
Yeah, sure. So about 10 years ago, our co-founders, Heidi Janengo was a physical therapist and ran a clinic, and her boyfriend at the time was a developer, and she tried to find an EMR that she could use across her clinics. Everything was install, had to do on-prem, yeah. And so they kind of started to build this for her clinics, and over time realized here's a problem that everyone is having. I think at the time only about 15% of PT clinics were on an EMR or any of that, and so 10 years later, market leader, it's totally flipped. Only about 15% are still on paper. So yeah, they saw the problem, they built it, and we've stayed laser focused in that rehab therapy space.
I mean, isn't this fantastic?
Yes.
And if it only happened more often, one would be so happy.
Well, that's what I was going to say, Charles. You are so aware of so many different technologies that are trying to solve a problem that just aren't that simple.
Yeah.
Right?
Yeah, no, because what you've done is, I mean, talk about a crying need. Look at all those wasted appointments. Look at all that chaos in communication. Look at all that misalignment. Mm-hmm. I mean, the whole thing is just disastrous. And doing something, I'm not saying it's simple, but intuitively, it's relatively straightforward.
And one of the things we saw were a lot of the larger EMRs worked for the physicians, but not for the therapist, right? They have their own workflow, they have flow sheets, a lot of different things, and it's not a single, one time a year appointment. You're going through a course of care, 10, 12 visits. So how do you manage that? How do you keep them engaged in that process?
So now you guys have scaled up. I don't know how many clients you have, but now you have a lot of data. So has that brought up a whole new issue of how to protect it?
Oh yeah, so we have about 15,000 clinics, so we're the market leader in our space. And for us, we looked at it very, very critically because we have a huge amount of data. Got ISO certified a couple years ago, and really are leading that charge in our area to say, okay, we have millions of patient records, all these different things. So making sure that is secure, but they can access it, has been something we're very focused on.
Great. And what for you do you see as being the future with your technology?
For us, it's really about the patient experience and patient engagement. We launched a patient relationship management product last year, because what we're seeing is almost a third of patients are dropping off in those first 3 visits.
Right.
So how do we keep them engaged? How do we get them doing their exercises at home and completing that course of care?
Yeah.
And the potential here is enormous, because if we look to what's happened hitherto in terms of the number of people who really do the exercises they're supposed to do.
Yeah, right.
I wouldn't want to bet how many they are, but I don't think they're the majority.
I know. Do this 20 times.
Yeah.
And even getting them into therapy. Yeah. So we ran some numbers, about 90% of people who could benefit from physical therapy actually make it into physical therapy.
Yes.
So, how do we help with the opioid crisis through physical therapy, all these things. And so major problems we're trying to deal with and trying to get the awareness out there that people can go to
and
physical
it's even
therapy.
bigger than that. How do you help with people who are growing older maintain physical activity? We know that affecting that can actually affect everything from strokes to dementia.
Yeah.
So this is really important.
That would be really interesting to see whether or not, you guys have had the advantage of building something from the ground up, probably very deliberately. I want to believe your UI UX is awesome, and whether or not you have the ability to, because of its being easy, that you can get older people on it. But we'll just have to see. It's really nice to meet you in person, and thank you for being on our show.
Thanks for having me. This has been great.
Thank you. So in the past couple days, I've been lucky enough to hear about people who have created initiatives, built frameworks, and you always hope that you hear amazing metrics. Well, I'm pleased to say that this conversation will blow your mind. With us now is Blaine Newton, who is the Executive Vice President of HIMSS Analytics, and Dr. Ann Snowden, who's the Scientific Director and CEO of SCAN Health. Hello, you two. Thank you so much for joining us.
Hello.
I know HIMSS Analytics has a number of different initiatives, and one of the frameworks that they have been working on is something called the HSIM. So why don't you kick this off by telling us what that is?
Sure. So the HSIM, Health and Supply Information Maturity Model, is the latest maturity model that we brought into our larger portfolio of maturity models that started with MRAMs, or an EMR adoption model. And those frameworks and models are really intended to help guide healthcare providers and health systems and public health agencies around the world understand kind of the steps it takes to leverage technology to improve outcomes. We recognize, after doing a fair amount of research with the provider community, that operational performance, financial optimization, system optimization is a top priority for providers. So before you can get to the true clinical outcome improvement, you need to kind of optimize what you have and extract value out of the significant investments that have been made. And we're just not there yet. And so we see the HSIM model, which Ann Snowden built through years of research, and she'll explain in a little bit, as a way for us to capture the value and optimize the infrastructure that's been built over the last decade in healthcare through the EMR adoption. And really, it's focused on clinically integrated supply chain and the opportunities that come from that linkage of supply chain systems and clinical systems. And we're incredibly excited about it. There's been a lot of buzz and conversations around it on the floor. I think it has the opportunity to truly change healthcare.
Very interesting. Like, what drove this drive to improve the supply chain for providers? Has this emerged as a recent challenge? I know it's always been there, but sort of why has this now come to the forefront?
So it's a good question. It's actually a recent solution to a challenge we've had in global health systems for decades. And the primary driver for me as a nurse is medical error. So when you go into a hospital setting or a clinic as a citizen, you expect and hope to get the very best care possible. But the truth is, there's really no global health system in the world that tracks and traces every patient, every care procedure, every product used in care, and maps it to an outcome to know what's working best and for whom. That's what the HSIM tool does. So how does that help us with medical error? Well, some of our medical errors are pretty challenging. If we put a hip implant in that joint because you've fallen and broken that hip, how do we know that hip implant has been recalled? We don't.
Wow.
Unless you track and trace every patient, every care process, every product we use in care to an outcome, we don't know who does very, very well with that hip surgery, who doesn't do very well, and how does the health system learn from that real world data. What we have been relying on is clinical trial data. So all our wonderful clinicians, researchers run clinical trials and say, guess what? That's the best surgery for you, and this is the prosthesis we're going to use. Wow. We know one size doesn't fit all in healthcare.
Right.
We know that women respond differently in certain care scenarios than men. We know Indigenous people have different outcomes than Caucasian people. Until you have an infrastructure in a healthcare system that can track and trace what care is received by whom, and did it work really well or maybe not as well, then health systems can't learn what works best for whom and under what conditions. This HSIM tool creates that possibility.
Wow.
So it allows us to overcome big challenges like error, but also quality, safety, and making the best decision for every individual citizen.
I love the fact, first of all, that you come from a nurse background and you have created this, right, or spearheaded it. You know, we had a previous interview with somebody who was talking about the power of Infram and really going into it and how it almost became like a checklist, right? Yeah. By going through it, they were able to recommend to their clients, there are things that you have to get rid of, or we recommend that you buy this. And initially the reaction was, are you crazy? But in that conversation, it became so clear that more and more, it became evident that that was real, right? That those are, and it seems like HSIMS has the possibility of potentially becoming almost like that checklist.
Right. So, and it actually takes you beyond the checklist.
Yes.
So if you know what care is working best for whom, and in what country, like how come each country isn't learning from the other countries on their great outcomes? So right now we've taken all the joint registry data from England and we're comparing it to Canada. We're going to soon add the US and the Australian data. So we can start to understand if you're between 85 and 95 and you have the following health history, what's the best care, surgical care for you, and which one's got the best outcomes so that you can go home and live independently. Why can't we learn health system to health system? Because we all are in the same boat. We all have way more patients than we can deliver care to. Yeah. We're spending way more money than our country's GDP is generating.
Right. And wasting some of it.
And lots of waste. As soon as you implement a clinically integrated supply chain, in the 3 countries who have done it, their supplies cost drops by 30%.
Wow.
I've never seen an innovation create that outcome. Their labor cost, which is probably more important, drops 33%. Because it makes our environments easier for clinicians to work in. So as a nurse, when I give you a medication, the clinically integrated supply chain double checks for me it's the right drug, right dose, right time, right patient, and the right route to give it in. I never had that as a nurse.
Yeah. Wow.
So this is solving challenges for our clinicians, making it easier for them to give excellent care, and making sure every citizen knows exactly what care we gave them so they can make good decisions on the basis of what's right for them. Not what a clinical trial says, which is great, but I may not be that clinical trial patient of yours. I'll tell you what, I need to make that happen. So it really engages the patient citizen much, much more directly.
Wow.
There's a couple of big things that Anne just highlighted. In terms of the efficiency and cost savings gains, just to kind of level set that contextually, in the pilot sites that we've worked with around the world in Alberta and at Mercy Health in St. Louis and in the NHS, we're seeing 8-to-1 return on investments early stage in the model. You're seeing, and that translates to hundreds of millions of dollars, billions of dollars for those systems that can be reinvested in consumer-centric care. And it's such a powerful story. The other thing that this highlights, that Anne highlights here, is really a fundamental shift for HIMSS analytics and moving beyond just adoption and use to outcomes. So getting to the why here, so understanding why this is important. There's a lot of really cool things happening on that floor, and it's helping to understand the impact that those can have in the right circumstance, in the right process with the right people. And HSIM is really our opportunity to tell that story in a very impactful, powerful way globally.
Wow. Stephen, I mean, in your world, is that impressive? Because for a layman, I think that's awesome.
It's very impressive. I mean, certainly I've never heard the kinds of returns in a supply chain implementation in a traditional, more broad horizontal environment in IT yielding that kind of result.
Right.
I mean, the other question I have is, do you expect that kind of return to continue as the model is rolled out globally? right? Or will it begin to either will accelerate further or potentially slow down as it hits other markets, or as markets perhaps mature, right? Perhaps as you begin to enter markets with more, hospitals at a much more advanced state, whether it's in MRAM 7 or whatever, or 6, will that begin to impact, or will it begin to lower the amount of returns that you see here, or will it have no impact at all?
So that's a good question. It's often the thinking that, oh, well, it's great to save that much, but so what happens next? We have data from 10 North American hospitals. That 30% cost savings just on supplies is annualized. So every year, that CFO is achieving a 30% savings to reinvest, which allows you to scale it. Here's what we haven't measured yet. What's the cost savings of avoiding a near catastrophic or life-ending error? Right. If I, as a nurse, can make sure I never give the wrong medication, and then we actually calculate the avoidance of error and the cost that brings, then the numbers are much more likely to be greater than 30%. How big? We don't know. Error today is the third leading cause of death in North America in healthcare. So if we removed even half of that error in North America at that endpoint where we have this clinically integrated supply chain, that's a very big number. And that's what I'm after. Wow. Remove the error. And oh, by the way, you get great cost savings, much better quality, and every citizen can feel very confident in that healthcare system. And for me, that's the value.
And I get the impression you're probably not going to stop till you get it.
No.
So that's going to work out well.
I'm just getting warmed up.
Good. I love it. Well, we're so glad to have you on the show with such a moment of triumph to report. Thank you for being with us.
Thank you.
My pleasure. Thank you.
Yeah. Right on. So this has been an incredible 3 hours of conversations that we've had here at the desk at HIMSS 19. And I think if there's any type of angle or themes that have come up today, I would say that it's really identifying the people who are directly dealing with the healthcare, right? The patients, the clinicians and the providers and the innovators, whether or not they're people who have startups, data, cybersecurity, whatever else it is. And, the question then becomes, how do we get these people to work together? How do we get that the innovator understands that the clinician is busy? And how do we understand that the clinician understands how to treat the patient holistically? And then finally, how does the patient understand the innovations and use them to better their lives? There's just no doubt from everything I see here that this is confusing, but earlier we had Dr. Charles Alessi talk about the fact that when you innovate, you have a balloon, a water balloon, you squeeze one side, another comes up. You squeeze that, another thing happens. And that continues to make it confusing, but I can say with certainty that people are moving and trying to keep squeezing and make it better. So I'll leave you with that on day 2. Before we go, a final message from Ben Choder, who is the president of West DMS.
Thank you, Kate, and what a great day. And I hope everyone enjoyed day 2's programming as much as I did, where we heard topics across technology, precision medicine, and cybersecurity. We look forward to seeing what tomorrow has in store. So don't forget to tune back in and have a great day.